Alhamdulillah, wassalatu wassalam ala Rasulillah. I would like to welcome everyone to the second pediatric, to the second advances peritoneal dialysis symposium. Initially, I will give the talk to the supervisor of the scientific societies at the King Saud University, Professor Mohammed Al-Ubaid. Professor Mohammed, the mic is yours.
بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. أرحب بكم إخواني أعضاء الجمعية السعودية لطب وزراعة الكلى، وأشكركم على دعوتكم الكريمة لي لحضور مراسم الافتتاح وإلقاء كلمة، وأثمن لهذه الجمعية النشطة جهودها الكبيرة وأنشطتها المتعددة، والتي هي مصدر فخر واعتزاز لجامعتنا ولعموم العاملين في القطاع الصحي في المملكة. قامت الجمعية السعودية لطب وزراعة الكلى في تنظيم وإعداد العديد من الأنشطة والفعاليات الهامة، سعياً منها لتحقيق رسالة الجمعية في نقل المعرفة في مجال طب وزراعة الكلى، مما يصب في النهاية بتحسين الوضع الصحي والعلاجي لهذه الشريحة الهامة من المرضى، ورفع مستوى الخدمات العلاجية لهم تحقيقاً لرؤية المملكة وتنفيذاً لإرادة قيادة هذه البلاد للعناية بالمرضى وتقديم أفضل الخدمات العلاجية المبنية على أسس علمية متينة وبمواصفات عالمية تضاهي أحسن المستشفيات على مستوى العالم، حيث قامت الجمعية بتنظيم وإعداد 17 نشاطاً وفعالية متنوعة هذا العام، ما بين ندوات علمية ومؤتمرات وورش عمل أدارها ما يزيد عن 68 متحدثاً، وبواقع أكثر من 60 محاضرة، وبحضور ما يزيد عن 30,000 ممارس. ونحن اليوم بصدد بدء فعالية جديدة للجمعية، وهي ندوة علمية عن الغسيل البريتوني بإجمالي عدد ساعات 12 ساعة تعليم مستمر معتمد من الهيئة السعودية للتخصصات الصحية، حيث يحاضر فيها كوكبة مختارة من المتحدثين ذوي السمعة العالمية والمشهود لهم بالكفاءة. إخواني، إن الأرقام تشهد أن هذه الجمعية تقوم بمجهودات مشكورة ومتميزة، مما يجعلها في مقدمة الجمعيات العلمية التابعة لجامعة الملك سعود، والتي يفوق عددها 54 جمعية علمية، منها 22 تعمل في المجال الصحي. في نهاية كلمتي لا يفوتني أن أتقدم بالشكر لمقام خادم الحرمين الشريفين حفظه الله ولسمو ولي العهد على دعمهم اللامحدود للأنشطة العلمية في المملكة، ومنها أنشطة الجمعيات العلمية وتمكينها من أداء أدوارها. كما أتقدم بالشكر لمعالي وزير التعليم ولمعالي رئيس ولسعادة وكيل الجامعة للدراسات العليا والبحث العلمي على دعمهم اللامحدود. وكل الشكر لرئيس مجلس إدارة الجمعية دكتور خالد الحسن، وللزملاء الكرام فرداً من أعضاء مجلس الإدارة، وللجنة المنظمة للندوة. كما أشكر الرعاة والمشاركين المتحدثين والحضور من المملكة ومن كافة بقاع العالم، داعيا الله عز وجل أن يكلل مجهوداتكم بالتوفيق، والسلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته. يعطيك العافية بروف محمد. We are very pleased and honored to have you with us in the opening of this one of our medical events, educational events. So thank you very much for your presence with us, and thank you very much for your speech and talk. Actually, I will not add a lot what he said, Professor Mohammed, that we are very happy and pleased to have this events and to be organized. And as you know, and mentioned also by Professor Mohammed Al-Ubaid, since the pandemic of the COVID-19, we transformed to for virtual medical events rather than to stop our educational events. So since the last Ramadan, May, April, we had almost 10 medical webinars. And as well, we had a very big conference, which is the second critical care nephrology and hemodialysis conference, with almost more than 24,000 participants being registered. And it was the first one like it in the Middle East, as a total virtual, not only virtual with imagination hotel lobby, as well as the exhibition hall. Now we have our second big event, which is the second Advances Peritoneal Dialysis Symposium. And until today, actually, before we start, we have almost 14,000 participants being registered. And I can see now almost more than almost 2,300 is attending right now. So it's that's actually part of it is our colleagues, they believe on the society, and actually part of it is our selection of top-notch speaker, whether they are national, regional, or international, as well as a top-notch panelist in the Saudi Arabia. So without much delay, I would like also to thank our sole sponsor of this event, the Baxter Company. And as you know that with the Baxter Company, we have long history of collaboration with them. We had almost 10 PD forms that it is almost like a fundamental. We started with young fellows to train them. In addition, also the registrar to train them how to do the PD, and it is rotating in many parts in the kingdom. And we elected since last year, we start to have something advanced, which is the Advanced Peritoneal Dialysis Symposium. The first one was done last year, and this is the second one actually. And this one, it's a little bit more bigger than the previous one, as it is over 2 days, again with top-notch speaker from all over the world, and also top-notch panelists. Also, I would like to thank my colleague in the scientific committee, Professor Dr. Mohammed Sneed and Professor Ahmed Metwalli. And also, I would like to thank all our colleagues in the Saudi Society with doing this great job. I will not forget to thank also the company that we had. We start working with them for the last maybe 8-9 months. Event Group, they actually doing a great job with us and conducting all our medical events virtually. Without much delay, I will give my mic to Dr. Ahmed As-Salloum, our first panelist for the first lecture today. Dr. Ahmed, the mic is yours.
Thank you so much, Dr. Khalid, having us here. And we all welcome Dr. Martin Wiki, who is a consultant renal physician and oral professor at Sheffield Teaching Hospital, NHS Foundation Trust, and editor-in-chief of Peritoneal Dialysis International. He is actively involved in clinical research and is the chief investigator of the NIHR UK Peritoneal Dialysis Catheter Study, and is the Division 2 co-leader of the Yorkshire and Hamburg in the CRN. Welcome, Dr. Professor Martin, and the floor is yours.
Thank you so much to the Saudi Society of Nephrology and Transplantation, and to the whole panel, Professor Khaled Al-Shan, and to Ahmed Al-Salloum for inviting me and introducing me. I'm looking forward to sharing with you my thoughts around person-centered peritoneal dialysis. So I'm just going to get the slides up for you now. I hope you can see them. There we are. Okay, so my introductory slides. So a few minutes of your time to talk about person-centered care in peritoneal dialysis. So the first question is, what is person-centered care and why does it matter? So I'm just showing you a slide on the NHS National Health Service in UK long-term plan for overall health. So this is talking about all health conditions. And what I want to pull out for you are some really important concepts that I think all healthcare systems are wrestling with in the modern world. First of all, how to get people to be more involved in their own care, to take greater control over their own condition, how to support self-management, how to tackle health inequalities. So these are key goals. And at the heart of that is enabling the individual to understand their condition. Hang on a minute, I'm not sure what's happened. Can you see me?
No, actually, the slide is disappeared. So you need to share it again.
Something's happening. We've got a donut going around here. Something. Right. What's happened to it? Is it back?
Reshare the slide, the screen again. No, it's not yet.
It's not back. I wonder what happened. There's something going on. Please, no one. Don't panic, anyone. Something seems to be happening to this laptop. Oh, strange. Right. So there we are. Right. I will share the screen again. There seems to be
sure,
not responding. Weird. All right. Maybe we're back. Maybe we're back. 1 second.
Okay. Take your time.
Don't quite know what's happened to this. It's sort of gone into a donut. Well, let's try again now. See if we can do this. Share the screen once more. Here we go. Try to share. It has done something bad. 1 second. Is it back?
It's okay now.
Good. Okay. Interesting. This has never happened to me with my laptop before, but there we are. That's life. We're full of learning. Yeah. Okay. So here we are. Back to that slide. I was talking about what is person-centered care and why it's important. And the key issue is about focusing on the needs of the individual. So we would all agree to that, wouldn't we? So the Health Foundation, which is a healthcare or a charity in the UK, has tried to summarize the components of person-centered care. And just to bring them to your attention here, thinking about giving the individual dignity, compassion, and respect, coordinating care around that individual so that care is streamlined, if you like, and then, as I said before, enabling individuals to recognize their own strengths and develop those. And I think that's really, really important. And we can see how that fits into peritoneal dialysis. So this slide is described as the house of care, and it comes from diabetic management originally. And I know that across the world, diabetes is a big issue, but it talks about planning the care at the center and the different components around it that are necessary. So you need to have well-organized systems at the top here. You need to have clinicians who are committed to working in partnership, both with the patient and with the whole multidisciplinary team. And then the patient themselves needs to be informed and engaged and able to contribute to that discussion. And then you also have to have responsive commissioning. In other words, the commissioning of care has got to consider these issues, has got to consider how to prioritize the individual. And here's a paper by Rachel Morton and her colleague, just talking about person-centered dialysis. And you can see the different components. You could focus on the disease itself, you could focus on the patient, or you could focus on the person, how the person fits within their own family, within their own context, and how they might be involved in the design, in saying what matters to them as an individual. So, of course, there'll be many barriers to this, and Edwina Brown tomorrow will talk in more detail about this, the potential barriers to sharing decisions, and you can see that it's not straightforward. The individual themselves might not be in a position ready to accept their condition. The healthcare team might be nervous about sharing information, and the healthcare system might not permit enough time for people to have the conversations that they need to have. So it's worth considering the various barriers. So how should we go about commissioning person-centered peritoneal dialysis? So this is the National Service Specification for peritoneal dialysis that was being designed in England. I'm not sure where we are now with that because of the last few months, things have changed a bit. But the key thing is when it comes to peritoneal dialysis, we need that all suitable individuals have got the option of getting peritoneal dialysis. I'm trying to get the mouse to move. There it is. all suitable individuals. That means that those who need assistance should be given the opportunity to have that assistance. The patient should be informed so that they can be involved and make good choices about their own care based on shared decision making. And then we need to work collaboratively as a team to deliver this. So I've put this in this schema here, which I've used before, but there are 5 key domains that we need to think about as we design our care. So how do we get people onto peritoneal dialysis? That's domain number 1. How do we ensure that care is delivered at high quality? That's domain number 2. How do we individualize the care across the team so that it focuses on the needs of the individual? How do we consistently assess the patient perspective? And what do we do for people who've got many multiple conditions, who are frail, who need extra support? So those are the 5 things that we should think about. So if we think about getting onto peritoneal dialysis, here's a slide which I've used before. And it raises the question, why is it that although from evidence, 78% of people are potentially able to do peritoneal dialysis, across the world, only 12% of people are receiving it. So clearly there's a big gap between those who could potentially do PD and those who actually do it. And the absolute contraindications there are around the absence of a peritoneal membrane. So there are fairly few, the absolute contraindications. And the reasons why people don't access the therapy are complex, including the attitudes of healthcare teams, as well as the nervousness and anxiety around patients. And our approach to tackling this has to be around informing people and enabling people so that they can take a role in choosing their own therapy. Why do people like to dialyze at home? Why do they like to be independent of the hospital? And this is from an old paper talking about home hemodialysis, but I like it a lot. And this is a qualitative study, but they come out with 3 themes: freedom, lifestyle, and control. People like to be able to be independent and to take control of their own lives. Who wouldn't? Of course, there are a whole range of barriers that affect this. And I'm just showing you one slide here from the UK Renal Registry. In the UK, you can see socioeconomic status in terms of the level of economic wealth that people have. Those who are have least economic wealth, who are most deprived in terms of economics, are much more likely to dialyze in centre, whereas those and less likely to dialyze at home, both on PD or home HD. So I'm showing you that to say that there are structural barriers that we need to be aware of as we enable people to access home therapies. This slide is a composite that I've used before, and it looks at people who started their chosen modality of dialysis. Here on the left, the paper by Zolowski and Liebman, published in PDI, asking, why did you not get the modality that you selected? And there you can see a number of reasons that people articulated. They lacked confidence, they didn't have enough education, they were influenced by others who said, maybe it's not for you to be at home. So the issue is this mismatch, and I've put this in the panel here. The person with the mismatched socks, I don't know if that's ever happened to you, but you know, the mismatch between what people wanted and what they got. Why does that happen? Here is a peer support program from Birmingham, where we have quite a large population of people from of South Asian origin originally, and the best way to enable them to go into PD is to have peer support workers who are of similar ethnicity, and people feel that they can access and communicate and work with those individuals, and that enabled a greater proportion of people to get onto home therapies. And this is about health literacy, this panel on the right, just to tell us that we need to present information in the sort of way that people can understand. There's a lot of interest now in goal-directed dialysis. This is a KDIGO document that was published in KI last year, talking about initiating dialysis and just saying that as we think about prescribing dialysis therapy, we should be considering the goals of the individual. And there's so many different components in the panel on the right that make up the quality of dialysis treatment. And it's important to prioritize what matters to the individual. You know, how much time are you going to spend on this treatment? How much time are you going to spend with your family, with your children, doing the things that matter to you? And the International Society of Peritoneal Dialysis this last year has published a very comprehensive prescribing guideline for peritoneal dialysis. This is available at ispd.org to download for you. And it talks again about goal-directed PD. So you can see in this panel, this is the infographic that came from the main paper, the number of different domains that need to be considered as one's adjusting the prescription around the person. So for example, obviously shared decision-making, what matters to you? If you're frail and elderly, what are your priorities? You may want to spend more time with your family, less time doing intensive dialysis. Clearly preserving residual renal function is an important goal. What about thinking about children? What about thinking about resource-constrained environments? How about quality of life against volume status and all these other things? So this is sort of bearing these different components in mind. Are we doing all right? Did you want me to finish or something? I heard someone interrupt. I'll continue for the time being. So what are the key gaps that we need to address? And I think one of the key things is quality. How do we keep people on the therapy when we've initiated it? And you can see the causes of technique failure there listed from this Australian paper: inadequate clearance, infection, psychosocial, catheter, mechanical. So the main things are infection and access, making sure that catheter works. And of course, there's good work now coming out of the Peritoneal Dialysis Outcomes and Practice Pattern Study, an international study looking at the patterns of peritoneal infection across 7 different countries. And I'm going to show you data on that tomorrow. But I just want to talk about the patient experience. This is from my own center, people presenting with peritonitis. What did they experience? Had we trained them adequately? And of course, when we spoke to them, one of our trainees spoke to the patients. They weren't very clear about what they should be doing. So despite the education we gave them, there was nervousness. They weren't sure how to recognize the infection. They weren't sure who to contact. And so that just tells us how we ought to improve the way we work with our patients to enable them better. And this has been put together in a paper in PDI by Denise Campbell, looking at the experience of peritonitis. And you can see the themes there that people are really worried about: the invading harm, the life-threatening nature, the exasperation of having to attend hospital, the impact on lifestyle, and so on. So thinking about the patient perspective is so important because it emphasizes the need to try to minimize this risk of infection that people face. And of course, PDOPS has published in NDT last year, looking at the practice patterns across those different countries. And the reason why I'm highlighting you this is just to show variation, for example, in antimicrobial prophylaxis for the exit site between countries. And that's really despite a guideline. Here we have an IFPD guideline which recommends such practice. And this just tells you from that paper, the NDT paper, variation in PD infection prevention and treatment strategies exist. And clearly with limited uptake of guidelines. So we need to think very carefully about how do we apply the evidence that we have to benefit patients at the heart of care. The second aspect, as I mentioned, infection as a cause of technique failure. What about access? And we've got accumulating information now about access. This is laparoscopic catheter insertion, a meta-analysis of cohort studies showing evidence of potential advantage. For example, reduced catheter obstruction or catheter migration in these cohort studies. They're not randomized controlled trials, but how do we underpin that sort of information? And this is data from the North American PD Catheter Registry published in PDI recently. This is of laparoscopic insertions, and you can see the sort of burden of catheter complications at around about 20%, 1 in 5 catheters having some kind of problem, 10% having flow restrictions. So we've got work to do on quality. And I put it to you that having a registry that collects this data is really helpful. This is data from the UK Renal Registry, looking at the first access used for people starting renal replacement therapy in the transplant centers. And you can see small percentage starting with a preemptive transplant, a certain group starting with PD. And then if you look at the rest starting on hemodialysis across here, not so many of them starting with fistulas, many starting with lines. And it's really important to have that sort of information so that one can improve. We can't improve our care unless we know what we're dealing with. What about the final theme I'm going to cover? Life participation. It really matters to people that they can be involved in life, the things that matter, daily living, work, study, family, travel, hobbies, all of those things. And PD, of course, has got particular advantages there in terms of enabling people to be independent of the hospital and continuing to get on with their own life. These are some of the things that matter to people from a qualitative study in terms of empowering them to lead their lives, overcoming constraints, adjusting their therapy around their lifestyle, trying to do something about making it more flexible, having supportive relationships, which are very important to our patients, enabling them to feel resilient and strong, getting greater clarity around self-management. I'm interested in this. This is a paper published recently around burnout, a qualitative paper asking what impacts into burnout. And here we can see on the left-hand panel, suffering and unrelenting responsibility. This treatment goes on and on and on. You know, it just goes on for day after day. How can I cope with that? Well, how do you enable people to be resilient and to adapt? And there are all sorts of things you can do over here on the right. Draw on inspiration and support from the family, relying on faith and hope for motivation, finding meaning in other activities, and ensuring that people are adequately supported. So there's a lot that we can do there. Remote monitoring also helps. And here's a thematic analysis of caregivers' perspectives and patients' perspectives on remote monitoring for peritoneal dialysis, just showing that there's experience around reducing the burden through enabling greater reassurance and support and helping people to feel that they are not alone at home through remote monitoring. What about understanding what matters to people on a consistent basis? This is a paper from NDT talking about collecting patient-reported outcome and experience measures, and a study from Australia. And indeed in the UK now, for the last 4 or 5 years, we've been running a patient-reported experience measure of kidney care, and that runs every year, and it gives us good information about what matters to patients. And here we've got from 16,000 patients, of whom about 1,000 are on peritoneal dialysis, what really matters to them. And you can see scored about lowest is sharing decisions about your care. So patients feel good about privacy and dignity and patient information, but they don't feel that they're really getting a good opportunity to share decisions. So that indicates to us we need to do more work in this domain. And then, of course, frailty, I mentioned very briefly. This is from PDOPS. It just shows you on the left-hand panel the variation in frailty between countries. And on the right, I put in a paper about carer burden. It's really important to consider the carer. And this paper shows that after a year of caring for someone on peritoneal dialysis, that carer is becoming tired and is not being as good as they were when they started. So again, we need to think about support mechanisms. Here from C. Jason, a recently published review meta-analysis, if you like, of assisted peritoneal dialysis, and their conclusion was the studies are very heterogeneous, these 34 articles, so they couldn't really draw any conclusions, but in that paper is a very good summary of what's involved in assisted peritoneal dialysis, the components of setting up the machine, enabling the bag exchange and disposal, providing personal assistance, documenting the measurements that you need, ensuring the medication is administered, and assessing volume status and preventing infections. So all of those different parts that we need to think there. Okay, so I'm going to wrap up. How can we enhance person-centered care in peritoneal dialysis? And I've covered a number of domains. We need to think about how we enable people to get onto PD. We need to ensure the quality of care we deliver is to the best standard. We need to focus on the individual and how the team comes together around that individual. We need to consistently assess what matters to people, and we need to think about people who are more frail and how we support them. And I'd like to say to you that I think having a registry is a really good way of collecting consistent data. I think that's would be a really important step forward. I've been involved recently working with a group who are working with you guys and with the Saudi government on developing a dialysis strategy. PricewaterhouseCoopers are commissioned to work on that, and I'm just drawing it to your attention because I'm aware that this is going to be happening over the next few months. And clearly some of these themes are really important and dear to all of our hearts. And I know that these really matter to you as well. Talking about virtual meetings, we'll be running the ISPD conference virtually, ISPD Euro PD joint conference virtually from 28th to February to 2nd March. We would love to have you involved in that Congress. We've reduced our fees now to £250 from 500 because it's going to be a virtual meeting, and we look forward to having you there. So thank you very much for listening to me. I'll stop sharing my screen and take your questions. So thank you very much.
Your mic, Ahmed, your mic is mute.
Thank you so much, Prof. Martin, for the lecture. It was outstanding and excellent. I really enjoyed it personally. before we we have about now 9 minutes, and we have a couple of questions, and I would just say the things which are related to your lecture. It says here, I believe PD as a modality is very underutilized in many countries. How do you explain the difference between countries in PD as method of renal replacement therapy, like between Canada and UK?
Thank you for that really important question. And tomorrow in my talk, I'm talking about literature, and I will show one or two slides on the variation across the world. There are a whole range of practice patterns, and indeed, Professor Wim van Biesen, who's on the panel, has published in this area too. But for example, there are some countries that have got PD first policies, like Hong Kong, for example, is very famous for that. Thailand has recently adopted that approach and has increased the access to renal replacement therapy enormously in that country by doing so. So there are policy-related factors at a country level. And then there are, key components which enable an individual to participate. So for example, ensuring that there are good educational programs for patients as they approach the need for dialysis, because that gives people a chance to learn and gain confidence and make choices about participating. And we know that where there's a large proportion of people starting dialysis as late presenters, that they're much more likely to start in center-based hemodialysis because they haven't had a chance to think about and choose what matters to them. There are a whole range of barriers, financial barriers, of course. It's really interesting in the United States that they've changed their funding model. And as a consequence of that, in the last 8 years or so, PD has doubled as a modality. So they changed the funding model so that PD wasn't financially disadvantaged. So I think it's really important that the funding model enables that too. And then also there are our own prejudices. It's very easy for us to look at an individual and say, no, I don't think you should do a home therapy. I think you should dialyze in center. And when we do that, what we're actually effectively doing is we're depriving that person of their liberty. We need to think very carefully before we make that sort of statement. So we have our own individual prejudices as well. So it's very, very complicated. And across the world, there's huge variation from, sort of the top of the heap, places like Hong Kong, to some countries where there's no PD at all. And obviously, I think we need to work towards using PD as a therapy which is complementary to hemodialysis and transplantation in managing people with renal replacement therapy. So thank you for the question.
Thank you so much, Prof. Martin. And there's one of the questions which says, it's very basic, but it will draw me to another question I will ask you myself. The question says, how the doctor choose the type of dialysis to a patient. And in your nice illustrated lecture, you mentioned a lot of factors related to the patient. And I believe that we should have two parallel themes or factors, patient-related and physician-related. Because if we need to, as you just now said, that the physician simply can't deny a patient for peritoneal dialysis home-based, he needs also to be educated, and he needs also to be well equipped to decide for a patient.
I absolutely agree with you, Ahmed. I think you've put it very nicely there. We all need to be informed and enabled so that we can see the potential. And if you live in an environment, if you work in an environment where you don't see many people who are looking after themselves at home, then you don't see that. You're not exposed to that. And you don't realize it can happen. And you also don't know what it means to individuals. So that can easily happen to us. We see in the UK, we see the same range of variation in terms of people getting onto home therapy as we do across the world. Some units with very little, other units do a lot. And I think it comes down to the unit culture and to ensuring that the doctors and the nurses and the patients all have plenty of education around what it matters to be to look after yourself. There are 4 ethical principles upon which medicine is based, and one of them is autonomy. And we need to remember that, give the person a chance to be supported, to be independent if they can. Of course, our kidney patients very quickly give up their autonomy and become institutionalized. I put it to you that we all become institutionalized easily. Working within the hospital, it's easy to become institutionalized as well. And we have to think about that too. So yeah, it's a good question. Thank you.
Thank you so much, Prof. Martin. And we really enjoyed the lecture. And I believe we spared about 2 minutes more for the next panel. Thank you so much.
Okay, thank you very much for having me. And I'll have to go to a clinic shortly, so I'll stay for a bit and then I'll leave. Thank you very much indeed. I really enjoyed participating. Thank you very much indeed. I wish you all the best for the meeting.
Thank you very much. We go on to the second talk, the speaker and the panelist. So kindly, if you could share your slide.
Should be okay now, I think. Can you see the screen?
Yes.
Okay.
Thank you very much. Yes, it looks perfect. Go ahead, Victor.
Can we start then?
Good afternoon. I am Ali Al-Kathiri. I'm a nephrologist, assistant professor at Mulqara University, Mecca, KSA. I am pleased to welcome our next speaker, Professor Wim van Biezen, a very distinguished nephrologist and professor of medicine from Belgium. Professor Wim van Biezen has done a lot of work and major contributions to nephrology and medical field, has published hundreds of papers and wrote many chapters and books, and he is an active
You are mute, Ya Ali. You are on mute. Ahmed, can you unmute him, Ahmed?
He's done a lot of work in and major contribution to nephrology and medical field. He published hundreds of papers, wrote many chapters and books, and he's an editor and reviewer of many and of highly ranked journals in nephrology and medicine. Today he will be sharing with us his expert opinion and assessment of peritoneal membrane state of an art in 2020. With that, I will ask your full attention to Professor Wim van Biezen. Professor Wim, please go ahead.
So thank you very much for the nice introduction, Professor Al-Kathiri. Also, thank you very much to the scientific committee of the Saudi Society of Nephrology and Transplantation, who invited me to give a 25-minute lecture on evaluation of peritoneal membrane characteristics and how we can do that in 2020. Now, I am referring a bit to a paper that we wrote 10 years ago, which was a kind of guidance document established in the framework of European renal best practice. And you can ask, of course, the question, is what we produced in that document, what we recommended in that document 10 years ago, still suitable in 2020? And also, what have people done in the remaining 10 years or in the past 10 years to bring this guidance into practice? How has it been implemented in real life, everyday clinical practice? Now, the first statement that we made 10 years ago with our advisory board was that peritoneal membrane testing should be done to guide the prescription of PD therapy and to follow the evolution of the function of the peritoneal membrane over time. And there were some considerations that made us believe this was a good recommendation, because we believed that having the right treatment for the right patient, meaning that you adapt the treatment to the peritoneal transport characteristics, would decrease overhydration, would avoid malnutrition and uremic complications, and would also lead to less metabolic disturbances. And the question is, of course, do we really need formal peritoneal membrane testing? Because if we are thinking about peritoneal membrane testing, if you give a lecture on peritoneal membrane testing, people are always talking about very complex things like double mini-PET test and like osmotic conductance for glucose and interleukin-6 and whatever. But in fact, you can do very straightforward and very informative tests already from the data that you receive from the patient that he brings in his agenda, in his daily notes that he makes as a result of what is coming in and out of his belly during the peritoneal dialysis procedure. And I believe this will be even more easy if we consider that we have now the remote monitoring options where patients can be online bringing in the data we need. And in fact, it's very easy. If you have a fast transporter, you would expect that there is negative ultrafiltration in short dwells with a 1.36. So even in dwells less than 3 hours, you will see that there is negative ultrafiltration, which is quite a hallmark, a sign of that the patient is being a fast transporter. If we're talking about a slow transporter, you will see that there is sustained ultrafiltration even in dwells longer than 4 hours if you're using a 1.36% glucose. So then you have a slow transporter. So you can already make a very good impression of what the peritoneal membrane is like in terms of transport rate if you just look to the daily notes of your patient. You don't need very fancy, expensive, difficult to perform tests to get that information. And it's really important that you can do that and that you can adapt the treatment of the patient accordingly. Because if the patient is a fast transporter, he will need short dwells. If the patient is a slow transporter, he will need longer dwells. You will have to increase the dwell time in this type of patients. Now, if you want to do a formal test of peritoneal membrane capacity, for example, for a study, or because you want to do a yearly or a half-yearly checkup of your patient, the most easy thing to do, the most convenient thing to do, the most knowledgeable thing to do is, of course, the peritoneal equilibration test already introduced more than 30 years ago by Twardowski. And in fact, you have to realize that the peritoneal equilibration test is a graphical expression of diffusion over time and of loss of osmotic capacity through resorption. So in fact, you will have a timeline in the x-axis, you will have a concentration line in the y-axis. And here you can see already quite a lot of the properties of the peritoneal membrane transport. First of all, there is differences between patients. This is very well known. We have the fast transporters and the slow transporters. Few people realize that even within a dwell, the transport rate will differ. This is because transperitoneal membrane transport is a concentration gradient driven process, meaning that if there is a large concentration difference, as is the case in the beginning of the dwell, the transport will be more fast, will be more rapid than at the later stages. And this is reflected in the inclination, in the angle of the curve, where you can see this is very steep in the beginning, and then over time, this will flatten. And this is more expressed in the fast transporters than in the slow transporters, where you can see that in the beginning of the dwell, there is not much difference to the end of the dwell after 4 hours. And of course, the opposite will be seen for glucose, where there is a disappearance, not entrance of a solute into the solution. So you can already see on this PET test, important information: is the patient fast or slow? How long can I keep this patient without getting negative ultrafiltration? How long will the glucose gradient be preserved? But you have to realize this is a very one-dimensional univariate approach of transperitoneal membrane transport, because you collapse a lot of different pathophysiological mechanisms into one test. At the end of the day, you only assess small pore transport. And this is a kind of effective peritoneal membrane area that you're trying to define, a combination of different parameters through each other. Different parameters, meaning that there might be impact of interstitial fibrosis. I will come back to that later on. There might be differences in genetic polymorphisms. There is a lot of studies showing a very good correlation between fast transport status, interleukin-6 polymorphisms, and of course, a worse outcome in these patients. But also, for example, underlying comorbidities like diabetes, like cardiovascular disease, where the vascularization of the peritoneal membrane will be less good and lead to slower transport status in these patients. Now, how have people taken up this in real clinical practice? How have these guidelines that we issued 10 years ago been picked up and implemented? Well, this is a survey that we've done in the framework of the iPod PD study. This is an international registry study, including incident patients, over 1,500 incident PD patients. And you can clearly see that about 1 in 3 of these patients has got one evaluation of the peritoneal membrane characteristics. And you can see also that in those who did have a peritoneal membrane test evaluation, as you could expect, most of them are average transporters. Only a minority are fast transporters, only a minority are slow transporters. And you can see that depending upon the region, the chances, the probability that you will ever get a formal peritoneal membrane testing might be different. For example, if you see in Western Europe, it's around 40%. If you go to Asia Pacific, for example, this goes down to 2.4%. And the number of tests that are done in different patients per year also differs. It's very high in Asia Pacific, it's lower in the Western world. But what is important, and what was also a statement at the time that we wrote that guideline, is that there was an impact on mortality. If you were a fast transporter, it was presumed that your outcome would be worse. And indeed, this is what you see in this study of David Johnson. There is a correlation between transport status and the hazard ratio for mortality in the multivariate analysis. However, there is an important caveat. In the study of David Johnson, it was indicated that if you are a fast transporter and you are placed on APD rather than on CAPD, meaning that you are more likely to get short dwells rather than longer dwells, that this difference in mortality might be positively impacted and that these patients had a better outcome. So if you're a fast transporter, your outcome is better on APD than on CAPD. Opposite, if you're a slow transporter or if you're a fast transporter and on CAPD, your outcome would be worse. So if you're a slow transporter, you need to be on CAPD, you need to have long dwells. So this was in line with what we recommended at that time. In the meantime, some other additional information on this has become available. Indeed, the outcomes of our patients on peritoneal dialysis are associated with transport status, and there seems to be an indication that indeed a faster transport status might be not a good sign for your patient. For example, there is this meta-analysis 2006 from Brimble, a relative risk of 1.15. But in the meantime, we have the global fluid study, we have the DAVITA database, and they all point to the same direction, that it's probably not so good to be a fast transport patient when you start peritoneal dialysis. And this is not only for all-cause mortality, it's the same for technique success and for your risk for hospitalization. And of course, you can say, and I'm sure that the question will come later on, well, if you're a fast transporter, should you then not be on PD? Should that be a contraindication to have fast transporting people on PD? Well, that depends. It would only be a contraindication if the cause of the mortality would be associated to the PD. So if the cause is only the fact that these people are fast transporters per se, then probably it would not make a difference if you would treat them on HD, because then they still would have the condition that caused them to have the fast transport status, and their mortality would not change whether or not you would place them on PD. First thing. Second thing is that if we look to technique failure in the iPod PD study as related to the overhydration status, then you can see that the more overhydrated the patients are, the more likely they are to change to hemodialysis and the more likely they are to die. And we all know that there is an association between fast transport status and overhydration. This is also data from the iPod PD study, where you can see as your transport status goes up from low, slow to average to high average, that your risk of getting overhydrated also increases. And quite remarkable, the patients where we do not know, where we do not have a formal testing of the peritoneal membrane characteristics, they have the worst overhydration. So part of the explanation why fast transport patients do worse than slower transport patients might be in overhydration. And we do have means to get that overhydration under control. We do have icodextrin, we do have the shorter dwells that we can use in faster transporters by placing them on APD to better get control of the volume status, and then most likely we will get better control of the associated risk of the fast transporters. And this is depicted here. You can see that the risk of getting fluid overload in these patients is of course associated to the geographical area. It's associated to age. It increases with age. There is more overhydration in males versus females. These are of course factors that you cannot influence. There is more overhydration in diabetics as compared to non-diabetics. You can see that in patients that are on polyglucose, there is a lower risk of overhydration. So pointing to the fact that indeed you can use icodextrin to get control of the fluid status. But most remarkably, or as I already told you some minutes ago, that if you compare to slow transporters, if you're a fast transporter, you have on average 700 milliliters more overhydration than a slow transporter. So basically, you can control that to some extent by using icodextrin in fast transporters, but the major task to be fulfilled would be, of course, to reduce the dwell length and to get additional ultrafiltration by doing that in that way. But there is a more striking question, because if you look to the data of the iPod PD study, then you can see that the fluid overload that we can see in the slow, the average, the high average, and the fast transporters, it is already there from the beginning. This means that the fact that the fast transporters are fluid overloaded is not something that is due to the peritoneal dialysis per se, because these data were measured before they started peritoneal dialysis. So this means that the fact that fast transporters are overhydrated is an intrinsic quality of the fact that they are fast transporters. This might be linked to the fact that a fast transport status might be a sign of inflammation. And indeed, we know that systemic and peritoneal inflammation is linked to peritoneal dialysis survival. There is an association between inflammation and survival. For example, here you can see that there is this is data from the global fluid study, that there is a link between the dialysate interleukin-6 inflammation marker level and the peritoneal transport rate, meaning more inflammation is more fast transport status. And this is of course already present before you start peritoneal dialysis, because this is an intrinsic factor of the patient. And you can see, I will continue, that if you make a stratification for patient survival, and you do that adjusted for peritoneal transport rate, for peritoneal interleukin-6 levels, that these indeed are associated, that the peritoneal transport rate disappears from the equation and is no longer a risk factor, that the only risk factor that remains is the inflammation, the plasma interleukin-6 as a marker of systemic inflammation. So yes, high transport, fast transport is a risk factor, but it's not something which is attributable to PD. It's something that's attributable to the condition of the patient. It's a condition of systemic inflammation that will determine the outcome in these patients. And the underlying reason is, of course, that in the majority of these patients, the inflammation will cause the endothelium to be damaged, leading to higher leakage, leading to more protein loss, leading to more or less good ultrafiltration in these people. Second point, if you're performing a regular classic PET test, peritoneal equilibration test, a lot of people have the tendency to look to the D/P urea. This is probably not a very good idea, because the D/P urea is far less variable than that of the larger molecules. And you can see that on this graph. You can see that the difference between a fast transporter in urea versus a slow transporter in urea, it's very minimal. Whereas if you look to creatinine, which is only slightly bigger than urea, you can see that the difference between these categories is much bigger. And this is, of course, important, because if you look to the removal, the solute removal that you achieve in these people, you can see that in a slow transporter with a short dwell, you only have half of the amount of urea of creatinine that you will remove as compared to the urea. Whereas in a fast transporter in long dwells, this will equal up to nearly 0.9%. The message here is that if you're looking to urea removal, if you're looking to KT/V urea, you might stick your finger in your eye, because you are missing completely the removal of the smaller solutes like creatinine, like phosphate, like beta-2 microglobulin. And you will not have those into your equation if you're only looking to the D over P urea, if you're only taking into account KT over V urea to assess your solute removal in these people. It's very difficult to talk about membrane evaluation and forget about water and sodium handling. And if you think about it, small pore transport can never explain why and how we achieve ultrafiltration in peritoneal dialysis, because the reflection coefficient of glucose over the small pores, it's infinitesimally low, which means that you would not be able to achieve any ultrafiltration. So this is why we thought already before, it was modeled by Bengt Trippe, that there should be transcellular pores, which he called aquaporins, which would not allow any transport of any molecule except for water. And indeed, in later studies, it was found, there was found molecular evidence that indeed there was the aquaporins, which only allow the transport of water and which are transcellular pores that are present in the endothelial cells of the peritoneal membrane. And this gives us a very nice representation of how the handling of water and sodium happens in peritoneal dialysis. Because you have to imagine, there is the aquaporins, which are only permeable for water. They are not permeable for glucose, for example. They are not permeable for sodium. We have the small pores, which are permeable for water, but also for sodium and glucose. So at the moment that you're instilling a glucose solution inside the belly of a patient, you can see that the D over P sodium, the sodium concentration in the dialysate over the plasma sodium concentration, and you might know that the plasma sodium concentration is not going to change during a dwell. So the only thing that changes is the dialysate sodium concentration. Well, in the beginning of the dwell, there is a very high level of glucose in the belly, which will cause over the aquaporins a very strong force to attract water. Only water, because over the aquaporins, only water can pass. So you will have a movement of free water inside of the dialysate in the belly of the patient. And as a consequence, the dialysate concentration of sodium will decrease, meaning that the D over P sodium will go down. Yeah. This decrease in sodium will evoke or will make in effect that there is a concentration gradient between the dialysate sodium and the plasma sodium. And a concentration gradient, this means that it will drive diffusion of sodium, not over the aquaporins, because this is impossible, but over the small pores. So in fact, when we're looking to handling of water and sodium during a dwell in peritoneal dialysis, you can see that in the beginning of the dwell, there is pure water ultrafiltration over the aquaporins. This is, of course, induced by the hypertonicity of the glucose. And in the second part of the dwell only, there will be removal of sodium by diffusion over the small pores. And this has extremely important consequences in the management of your patient. Because you have to imagine, if you would stop the dwell here at this time, you would have removed a lot of water, but only water, not salt, which means that the salt remains in the patient, which means that the patient will become hyperosmolar, which will mean that the patient will get thirsty and that the patient will start drinking. This is not a good way to manage your volume status in your patient. Second point, if your patient is a fast transporter, because the diffusive transport of sodium is then much faster, you can see that there is nearly no sodium dip present. And this is important in the clinical reality. For example, in this case, you can see this is a 40-year lady with polycystic kidney disease. She has a good residual renal function. She has a very good ultrafiltration, and she's on a regimen with 5 very short cycles of 2.5 liters, 1.36 of glucose. Despite that, her KT over V is marginally good, 2.1 per week, but the lady has a very high creatinine level in her plasma, and she especially has a very high phosphate level. And she's hypertensive and she has edema, meaning that her volume status is probably not very well regulated. And if you look into this lady's transport status, then you will realize that she's a slow transporter. And this means that by having 5 short wells, she's in this situation, that indeed she's removing a lot of fluid. She has a lot of ultrafiltration, but the ultrafiltration is only pure water, which means that at the end of the night, she's extremely over osmolar active, and she will be extremely thirsty, and she will go to the fridge and drink a lot of water, which explains her volume overload, because she's still salt overloaded. We do not give her the opportunity to remove sufficient the sodium during her APD regimen. So this lady is a slow transporter, and she should be better off with longer dwells, probably in a manual CAPD setting. Third point, we also know that there is interstitial fibrosis in peritoneal dialysis. We know since long that there is epithelial mesenchymal transition, and that this will accumulate in the interstitial space of the mesothelium of the peritoneal membrane. And indeed, this is the case. You can see that this is data from Johan Morel from Brussels in Belgium, that in patients for a longer time on PD, there is accumulation of this fibrotic tissue, and this is even more expressed in patients with peritoneal sclerosis. Now, you have to imagine, if you are a urea or a creatinine molecule, or even a water molecule, and you have to travel from the inside of a capillary to the dialysate compartment, this is the distance that you have to travel. We call this the diffusion distance. But if there is something in the way, if there is fibrosis, the diffusion distance is not this, but you have to make a sideway. It's like if there is a queue on the highway, you have to make a detour, and the diffusion distance increases. This means that the interstitial fibrosis will also contribute to the slower transport status of your patient. And this is what you can measure in the double mini-PET test, where we measure the osmotic glucose conductance. Now, the formula looks very complicated, but if you look to it in more detail, you will see that in fact, what is written here is that the osmotic conductance for glucose is the difference in volume that you can achieve in terms of ultrafiltration with a 3.86 versus a 1.36, and that difference in volume that you achieve is due to the fact that there is a difference in osmotic capacity. So you just measure by increasing osmotic capacity, how much more ultrafiltration will I achieve? And this is a kind of property which is intrinsic for the peritoneal membrane. It's like a difference between a high flux hemodialyzer and a low flux hemodialyzer. They have different properties. And this is indeed a very good way to assess reasons for ultrafiltration failure in some patients. And it's a sign that there is something going wrong with the peritoneal membrane quality, that these people are accumulating fibrotic tissue, that these people are probably prone to develop sclerosing peritonitis in a later stage. Now, the only thing you have to be careful about when you're performing the double mini-PET test is that you need to do it in a proper way in terms of how you perform the procedure. And I will give you this example. One more minute.
5 minutes.
Yeah, okay. It's my last slide, so it doesn't matter. What you see here is that we try to measure osmotic glucose conductance in this patient, and we had a number of 2.4, which is very high, meaning that this patient has a lot of interstitial fibrosis. But if you look to the numbers, then you can see that the glucose that we measured at time 0 was 70.5, where we expect it to be 136. And in the 3.86, it was 191, where you expect it to be 386. And this indicates that there is a problem. The osmotic conductance for glucose that we calculated here is not correct, because there is some residual volume being left inside of the abdomen. And again, this has been nicely explored by the team of Johan Morel, who made a publication on that. If you perform the double mini-PET test, you have to be sure that there is no mechanical problem in your patient, and that the outflow of your peritoneal membrane is complete, because otherwise you get a mixture of fresh and spent dialysate, and you will see that your glucose concentration is not 136, but 70 at the beginning, which means that you're not measuring osmotic conductance for glucose, but that you're measuring a mechanical problem, and that there is an outflow problem in this patient. Last slide. So if you're testing peritoneal membrane characteristics, it depends what you want to know. For everyday clinical practice, you can just look to the notes of the patient to decide whether he's a fast or a slow transporter, adapt the treatment accordingly. If you want to assess small solute transport, well, the PET can do, but it might be better to have a mini PET because that's shorter in time. If you want to assess ultrafiltration capacity, it might be best to go for a double mini PET test because then you have all the information at one moment. You have the hydraulic conductance, you have the sodium sieving, and you have the transport status of the patient. And then, of course, it depends if your patient is overhydrated, if you want to assess free water transport, if you want to measure osmotic conductance to glucose, there is different tests that you can use. But this you can easily find in the paper, and I think these recommendations are still valid. I thank you for your attention.
Thank you very much, Professor Beason, for this outstanding talk. And we have a few questions. The first question, what is the impact of multiple antihypertensive medication in peritoneal membrane characteristic and PET testing?
Yeah, so there is different medications if they are acting on cardiovascular systems in terms of vasodilation or vasoconstriction. You can expect, of course, that you will end up with different results that might not be representative for the true status of the membrane of your patient. Because I will show this slide again. Here you can see that if you're measuring a peritoneal equilibration test, it depends upon the vascular recruitment of the capillaries. So if you're giving these patients vasoconstrictive agents or vasodilating agents, it might already give a difference in the transport status of that patient. But this is, of course, not a reflection of a change in the peritoneal membrane. It only has to do with how it actually will be measured by you. It can be different 5 minutes later.
The other questions from Salma, is the dialysis decrease the immunity for patient?
Is what?
Dialysis decrease immunology. I think it's we know that in the stage kidney disease dialysis patient has low immunity. So the other question probably why PD is not commonly used in KSA, and I think most countries has the same issue apart from Mexico and Hong Kong. But again, yeah, go ahead.
Yeah, so I think the reasons or barriers for the use of PD, I think Professor Wilkie already explored that and pointed out that it's very important to be motivated. We have done with EuroPD a recent survey some months ago to explore underlying barriers. And what comes out of that survey is that the most important factor is that you have a dedicated team. And all the other factors like late transfers, like the PD access team being motivated, like financial issues, they are all secondary to that. If you have a motivated team, you will find a way to end people on peritoneal dialysis. If you're not motivated, you will always find an excuse not to offer PD to that patient. So that's the most important factor. I think from the perspective of a patient, most patients would like to have a self-based treatment. Not all, it's about 30 to 35%, but this is still far above what we actually achieve, not only in KSA, but also in Belgium. So I think we are depriving our patients of the treatment that they would like more by making the judgments for them.
Has proved some advantage over hemodialysis, especially in the first 1 or 2 years. The other questions from one of the audience, how to prevent patient get thirsty after peritoneal dialysis? I think you alluded to this in one of your slides. Patient who
I cannot hear you. Your quality is very poor. The quality of the mic.
they're asking about how to what are the measures to prevent patient from getting thirsty.
Okay.
After,
yep. Very good question, I think, because this is key. We tend to measure ultrafiltration. We tend to measure, but to a lesser extent, urinary volume, but we forget that in the balance of overhydration, there is also the input. So measures to prevent patients getting thirsty, first of all, it's avoidance of hypertonic glucose. Because if you're using hypertonic glucose, you have to realize that in the first hour of the dwell, patients will get hyperglycemic. Even in non-diabetics, this might occur. If you're hyperglycemic, you're hyperosmolar, and you will get thirsty. Second point, salt intake. And I know this might be a very subtle point in KSA, because salt intake, you have very good food and very tasty food, but most of the time very spicy and probably also with a lot of salt. So this is very bad news, because salt is making you hyperosmolar and is making you thirsty. A third point, and often neglected, is medication. Drugs like alpha blockers, moxonidine, central acting antihypertensives, they all make patients thirsty. So this is probably not very good news again. And the mixture of those is probably not very good. So I think this is the first point you should make attention to. Last, if you're having a slow transport patient on short wells, you will remove a lot of water, but not salt. And these patients will get thirsty and they will drink. So you have to match the transport rate of your patient to the length of the dwell in that patient. Otherwise, you will get inevitably into trouble.
Okay, thank you very much, Professor Wim van Biezen, for
You're
your
welcome.
excellent vision. Thank you.
Thank you very much. We move on to the next lecture. So we'll ask Professor Franz Schaefer to share his slides, and Dr. Afaf, the mic is yours.
All right. Good afternoon or good evening.
Professor Schaefer, just 1 second for Afaf. Can you open your mic? Unmute your mic, Afaf, because she's the moderator. So, okay, go ahead, Afaf. We cannot hear you, Afaf. Afaf, we cannot hear you, Afaf. Yes, can you talk?
خالد
يا ايوه
صوت حضرتك واضح يا دكتور.
طيب. Yeah, my she have I think problem in the mics, Afaf. Can you take out your mics and maybe talk without that mics, another mic?
مايك دكتور عفان.
She's trying to buy another mic. Can you talk now, Afaf? Maybe
دكتور عفاف.
Okay.
دكتور عفاف.
Afaf, can you hear us, Afaf? Okay, so let me introduce Professor Schaefer. Then Afaf, she will deal with the question later on. Hopefully, by that time, she will fix her mic problem. So it's a great pleasure and very pleased and honor to have Professor Franz Schaefer. He's a well-known pediatric nephrologist and very well-known dialysis specialist. He have more than 600 published papers. He have so many clinical practice guidelines related to the dialysis. It's actually very great honors to have him with us in this symposium. So Professor Franz Shaver, the mic is yours, and go ahead.
Thank you, Khalid. Can you see my slide?
Yes, yes.
Okay. So thank you very much for the invitation. So I was asked to speak about the impact of PD fluid biocompatibility on the structural changes of the peritoneum and the functional changes of the peritoneum. And our group has done some work over the years in this field that I would like to share with you. So peritoneal dialysis is a very nice dialysis modality, as we have heard in the previous lectures. But it has the problem that we cannot run this dialysis modality indefinitely. After some years, there will be a loss of the ultrafiltration capacity. Patients tend to become fluid overloaded, and we have to discontinue this therapy. And there has been a lot of research trying to find out why this is the case and what can we do to expand the lifetime of peritoneal dialysis. So early studies of the peritoneal tissue of PD patients in adults have demonstrated that over the years, patients develop a massive submesothelial fibrosis and also a peculiar vasculopathy in the peritoneum, which resembles diabetic changes. And given the fact that this tissue is exposed to high concentrations of glucose, you can say that we are inducing a local diabetes in this condition. So probably glucose itself is a major player in mediating the toxicity of peritoneal dialysis on the tissue, but also it's known that during the sterilization process, certain glucose degradation products emerge that are highly reactive. These are mainly aldehydes, and they are toxic to certain tissues. And they were incriminated to be the major causes of a PD failure over time. Also, classical conventional solutions are buffered at a low pH, and this low pH may also be cytotoxic to some degree. A lot of experimental research has been performed showing that these factors, each one of them actually increases the production of certain inflammatory cytokines or transforming cytokines like TGF-beta and vascular epidermal growth factor. These would lead to these histological structural changes of the peritoneum that eventually lead to ultrafiltration and sometimes encapsulating peritoneal sclerosis, and also have systemic impact that we will come back to. Now, about more than 10 years ago, 15 years ago, the dialysis companies have started to tackle the problem of the formation of glucose degradation products by manufacturing these dual chamber bags where the glucose is stored in one chamber and the electrolytes in the other chamber. And so the glucose compartment can be maintained at a very low pH, and that greatly diminishes the formation of the GDPs. So we thought this solution is now giving us a set of more biocompatible PD fluids. Also, the overall pH after mixing the two solutions can be neutral. And in Heidelberg, we performed a local study in our children on peritoneal dialysis using the standard peritoneal dialysis fluid as compared to a bicarbonate containing biocompatible low GDP fluid. And when we treated these patients for 3 months, we were able to demonstrate that this marker of the peritoneal mesothelial cell mass dramatically increased with the new fluid, where it remained low when patients continued to be on the conventional fluid, and it came down when we switched the patients back from the low GDP to the high GDP fluid. So we thought, at least for the mesothelial cells, this fluid is indeed much more biocompatible than what we were using before. And in large registry studies that we are running in children on peritoneal dialysis with the International Pediatric Peritoneal Dialysis Network, the IPPN, we were able to demonstrate that the statural growth of small infants in the first 2 years of life exposed to biocompatible fluid was better than the growth of children who were maintained on conventional PD fluid. And since in the first 2 years of life you grow a large amount, this is a kind of sensitive measure of the status of the overall well-being of a patient, and especially of the inflammation status. So we thought that this better growth rates we see in these patients may be attributable to a systemic effect of the biocompatible PD fluids. Also, we looked by PET tests at the 4-hour DOP creatinine ratio, and you can see that with the bicarbonate, the low GDP fluid, the small molecule permeability of the peritoneal membrane slightly but significantly decreased, whereas it tended to increase with patients maintained on the conventional fluid. So we assumed that this is again a sign of less local inflammation, less vascular recruitment of the patients. And in a similar sense, this study from Australia in adults showed that the D/P creatinine ratio remained more stable in patients on a low GDP solution as compared to patients on a high GDP solution over an extended observation period of 2 years. So we thought we should document the impact of having these new biocompatible PD fluids available also on the tissue level. So my local colleague in Heidelberg, Klaus Schmidt, founded the International Pediatric Peritoneal Biopsy Study as a spin-off of the IPPN. And so far, some 25 centers in 15 countries have contributed a large number of peritoneal tissue biopsies, mainly from children that were starting PD and then having some intercurrent surgery or undergoing transplantation. And we also obtained tissues from healthy controls and also from some adult peritoneal dialysis patients. So this is now the largest biopsy study globally. For us as pediatricians, it was very interesting to see in the healthy children that the submesothelial thickness and especially the capillary density is not stable over time, but it shows some changes with age. And as you can see here, there is more, the submesothelial thickness is higher in children than in adults. And especially young children have a higher capillary density than older children or adults. And we all know as pediatricians that small infants tend to have less ultrafiltration and a high transporter state. And that was actually reflected by a higher blood capillary density. So we were most interested to see what would happen with the peritoneal ultrastructure as patients undergo peritoneal dialysis with the low GDP fluid. And we were somewhat disappointed actually, and it was contrary to our hypothesis to see that after 2 years on a low GDP fluid, this young child had extensive neoangiogenesis, or this child on long-term biocompatible PD fluid had also extensive submethyl fibrosis. And when we looked at the data in a statistical way, we documented that our patients had an increase of microvessel density, a distinct increase of vessel density in the first year of PD. They had an increase in the submesothelial microvessels and the overall blood vessel density. They also had an increase in their submesothelial thickness. So the endothelial surface area, because of the neoangiogenesis, increased by 60–80% over time. So indeed, we were not able to document reduced impact of the new fluids. However, the Achilles heel of this study was that we did not have controls on high GDP fluid, because everybody in Europe switched patients to the low GDP solutions, expecting with all the experimental evidence that this would have a beneficial impact, which we were not able to confirm in this pediatric population. Indeed, the peritoneal vessel density also predicted transport function. It was in the, sorry, I lost my cursor here. Here it is. You can see here there is a positive correlation between the microvessel density and the D/P creatinine, and an inverse relationship with the D/0 glucose. And this was an independent effect, independent of age, dialytic glucose exposure, and the submesothelial thickness. So it was really the microvessel density that was increasing that was associated with a higher permeability of the peritoneal membrane. Also, we looked at this is a little bit slow here. We looked at cytokines, cytokine expression in the tissues, and we clearly found a steep increase in VEGF abundance in the tissues after even less than 6 months. Within a few months of peritoneal dialysis, VEGF levels increased to a peak at around 1 year. And the same was true for phospho-SMAD, which is one of the intracellular signaling mediators of the TGF-beta pathway. But especially the VEGF increased, and that matched the angiogenesis that we saw on the tissue. We also found a cellular infiltration of the peritoneum with the low GDP fluids, quite marked. And as a synopsis, you can see here there is a very early increase in the blood vessel density, no change in lymphatic vessel density, and a slowly increasing vasculopathy over time. Submesothelial thickness increases after 3 to 4 years. We have an early increase in inflammatory cells. We see some EMT, and we have this early pronounced increase of VEGF abundance. Okay. So we did not have a direct comparison, but with what would happen on high GDP fluids. But there is literature from adult patients, as I said, who underwent biopsy after various periods of time. And you can see here that the increase of the blood vessels over time was not as marked with extended PD in this comparator study. So we think that indeed there's even less angiogenesis with the high GDP fluids. So we're really a little bit puzzled by these findings. And when we published them, they gave a big blow to the hypothesis that peritoneal dialysis biocompatibility would protect the peritoneal tissues. And in this editorial, Peter Blake really argued that we were following quite low evidence when switching to our patients to the low GDP solutions, thinking these are the completely biocompatible fluids for the patients. A recent Cochrane review looked at the biocompatibility effects of the new fluids, and there were 42 studies reviewed, and the only high-level evidence that was really documented was that, oh sorry, no, I lost my, okay. The only high-level evidence that was provided was indeed that residual renal function improves with the use of neutral pH, low GDP solutions and urine output. And this was hypothesized to be related to the increased solute transport and the reduced ultrafiltration rate that we have with these fluids due to the angiogenesis that occurs and then increased fluid uptake or less ultrafiltration that would increase the urine output. By contrast, there were no unequivocal effects on the rate of peritonitis, the technique survival, or the patient survival. Sorry, there's a little bit of a delay here. Okay. Just have to be patient. Okay. So with all the nice tissues Dr. Schmidt had in his freezers, he thought that he should use modern technologies to evaluate the tissue effects of both the high and the low GDP fluids. And by the time we were also able to collect a significant number of tissues from patients that were exposed to high GDP fluids, so we could make a better comparison. So we looked at the local peritoneal effects in patients not yet exposed to PD fluid as compared to those exposed to high and low GDP fluids. And we used advanced methodologies like digital histomorphometry, single molecule localization, microscopy, and we also looked not only at the peritoneal, at the parietal tissues, but also we looked at the omental arterioles, hypothesizing that any changes in those omental arteries, which are covered by a thick amount of fat tissue, would reflect more of the systemic effect of the fluids on the arteries than when we looked at the parietal arterioles. So we kind of compared the omental arterioles to the parietal to see which of the effects that we see might be systemic effects. And in this omental tissue, we were able to perform transcriptomics, proteomics on the laser dissected arteries. And one interesting finding we made generally in all patients was that the exposure to PD fluid increases the arteriolar complement system, or it activates the complement system. So we clearly had an upregulation in the omics studies, both at the transcriptomic and the proteomic level, and in the staining studies later on of several components of the alternative complement pathway, including the terminal complex. And this was indeed related directly to the glucose exposure of the patients. When we compared the high versus the low GDP fluids, we clearly saw differences between the four groups that we studied. The controls, the patients with end-stage kidney disease, not yet on PD or just starting PD at the time of Tinkoff catheter implantation, the low GDP and the high GDP fluids. What you see here is the lumen to vessel ratio. So we look at the relative size of the lumen as compared to the vessel wall. So a low LV ratio would mean that the arterial wall is very thick and the lumen is partially obliterated. So you can see that we have already before PD, we have a significant reduction of this arterial lumen. And then we see a slight further decrease on low GDP fluids, but we see a much more significant decrease on the high GDP fluids. So in these omental arterioles, we see a much more marked pathology with the high GDP fluids than with the low GDP fluids. And when we looked at certain markers of the endothelial integrity, we found that there was indeed a disintegration of the endothelial cell layer when exposed to high GDP fluids. So this is the CO1 distance between individual molecules that we looked at here, and you can see that the distance is much higher with the high glucose solution than with the low glucose solution, which means that there are large, let's say, windows between the endothelial cells. And there's also, you can express that as the number of cells per micrometer, and you can see that even this is lower in the high GDP than in the low GDP fluids. And there's more apoptosis going on of the endothelial cells. Caspase 3 is measured here when exposed to the high GDP fluids. So now we were clearly able to demonstrate a much more pronounced pathology on the arteriolar level in patients exposed to conventional PD fluids as compared to those low GDP fluids. Recently, a research project was inaugurated in Europe. That's the Improve PD project. This consortium is interested in outcomes research, basic research into the pathomechanisms of PD, but also in the PD fluid pipeline and modes of action of different PD fluid components. And so now we are moving from the first generation, let's say, of low GDP fluids, so the first generation of low biocompatible fluids, to new fluids which contain other alternative osmotic agents like stevia and or added substances that have some cytoprotective effects. And these are the PROTEC solutions. And I would like to show you some results of a study with this very new fluid that contains a dipeptide, alanine glutamine, in addition to low GDPs. And when patients were exposed for 2 months to this supplemented fluid, you can see that the induced IL-6 cytokine release increased. So the activity of the local host defense increased under the treatment, and also the CA125, it increased quite nicely. So even starting from the low GDP fluid, you see an even greater mesothelial cell mass with the addition of this cytoprotective compound. Also, it was shown in this study that the semi-permeability of the PD membrane changed. So there was, on the one hand, less loss of high molecular substances, but a better transport of low molecular substances like potassium, phosphorus, and uric acid. So that's a very interesting compound and fluid development that will have to be tested in further studies. Our group performed some additional experimental studies using this fluid, and they were able to show, you can see here again, this Z01 protein on the endothelial cells, which was very low in the conventional PD fluid. It normalized completely by addition of the alanine glutamine. And also other markers of endothelial cell function and the junction protein between cells, they significantly increased with the use of this cytoprotective agent. So in summary, low GDP fluids cause an early increase in angiogenesis and also do not prevent late submethyseal fibrosis. High GDP fluids cause more marked, probably systemic arteriopathy. And glutamine supplementation restores mesothelial and endothelial cell integrity and local host defense and increases the membrane semi-permeability. And there's more promising work on what I would call second-generation biocompatible fluids currently ongoing. Thank you very much for your attention.
Thank you very much, Doctor, for this very comprehensive presentation. Let's move now to the question. There is the first one we'll start is, if there is any list for biocompatibility solution that will be highlighted for better practice outcome?
Well, that's very early to say. As I was trying to point out, there's not so much evidence for a better practice outcome with the so-called biocompatible solutions that we have currently on the market. Even though we now see that they may have some beneficial impact on the systemic level that was perhaps underexposed so far, but we would have to look at longer-term outcomes and cardiovascular, especially cardiovascular outcomes of patients on these fluids. And then there are several developments which are of course not yet ready for marketing, which also look quite promising.
Okay, thank you for this presentation. Also have another question. There is a new research about the taurine working and other L-carnitine working as a osmotic agent rather than glucose. What's your opinion about that?
Yes, there are several studies going on such alternative osmotic agents. I personally feel that the glucose itself is probably a major culprit in the transformation of the peritoneal membrane. And we really will eventually require to replace glucose by some other osmotic agent if we really want to make major progress in expanding the lifetime of PD. So there are some interesting developments ongoing, but again, this is still in the research phase.
Okay, good. Like, it's really exciting lectures. I have another more question. Like we know now there is in the market Peritoneal, Balance, and Becavera, Cambridge Trio, Fresenius. From your experience, which one you prefer to use it with your patient?
Well, we usually use Becavera, but I don't think there are so major differences between these solutions. Some patients on Becavera become alkalotic, then we switch to Balance, which makes a little bit less alkalosis. But you know, by and large, I think the differences are quite minor. Also, in the experimental setting, we do not find any very major differences between these solutions in terms of their cellular effects.
Okay, good. If you allow me one more question, there is one asking also about can tamoxifen protect peritoneal membrane?
Tamoxifen?
Yes, there's a question about that.
I have no experience with that.
Okay, good. Oh, do you know if there is any medication can we use it to regress the progression of peritoneal membrane? Like, can we use anticyclooxygenase 2 inhibitors as a trial to stop progression of peritoneal membrane injury?
Yeah, you know, there are some studies that used steroids, oral steroids, but you know, these are all uncontrolled data or anecdotal data. So we really have no good solution or no real evidence that any of these, let's say, anti-inflammatory agents would really help with the condition. You know, if you look at the slides over time, there is a very slow increase of the fibrosis and the vasculopathy, and you would have to probably treat patients long term with these anti-inflammatory agents, and then eventually I would think the risk is high that you have more side effects than beneficial effects from these medications.
Okay, good. Thank you very much for this presentation again. If we have time, we want to spend more time, but we have another lecture going to be presented by Dr. Ahmed. Thank you very much.
Thank you.
Thank you, everybody. So we'll move on to the next lecture. Professor Dr. Raymond, if you could share your slides, please. And Dr. Ahmed Al-Flew, the mic is yours.
You have my video. I don't know if it's appearing.
Ahmed, your video. No, I cannot see your face actually.
I cannot turn it on off. It doesn't work. I don't know why.
Shouldn't be problems. So let's go ahead.
Okay. Sorry for the. Hello. Good afternoon.
Hello.
Hello.
We can hear you, Raymond. We can hear you. Just can you share your slides, please? We can see the desktop.
Yeah, sure.
And
you hear me now?
Sorry.
Can you hear me now?
We can see you, but please share your screen, please.
Yeah, sure.
Excellent.
Let me see.
Just maximize it only.
Yeah. You hear me?
Absolutely, yes.
Sorry?
Yes, we hear you, Dr. Raymond.
Okay, you hear me. Yeah.
Good afternoon, Dr. Raymond. I am presenting.
Okay, so that's fine then. Yeah. Yeah.
Unfortunately, my video is not appearing, but I'll just introduce you. Dr. Raymond Credit is pioneer in nephrology and peritoneal dialysis since the 70s. In the Netherlands, he was heading the Department of Nephrology in the University of Amsterdam in the 90s. He contributed to the field of scientific research by more than 500 papers and received international and distinguished medal from National Kidney Foundation and other prizes. Currently, he is honorary member of the Netherlands Federation of Nephrology. As well, he is a member of the Scientific Advisory Board of European Renal Association. Today, he is sharing with us the prediction of encapsulating peritoneal sclerosis. So, Professor Raymond, the floor is yours, please.
Well, first of all, thank you very much, Professor Alview. And indeed, the idea is that I'll talk with you about how to predict encapsulating peritoneal sclerosis. And in this first slide, you see a post-mortem preparation of entrapped bowels in a patient with EPS. And of course, when you see this, the question is, can you prevent it? Can you diagnose it? But especially in the past, it often occurred just as a bolt from the blue skies. So indeed, the question is whether this is unavoidable or not, whether we can predict it or not. Well, first of all, then what are the changes in peritoneal function that precede EPS? Well, all EPS patients have ultrafiltration failure, but only 2% of new patients develop EPS. A small solute transport is not useful. It's often mildly increased, but no diagnostic value at all. And the third point is whether free water transport would be helpful. Well, that's first of all about ultrafiltration failure. Here, this is a slide from an old study from my unit, where you see ultrafiltration in a number of EPS patients, and you see indeed that the mean values are lower than in control patients, but that there is really an overlap. So that is not really helpful. Which brings us then to free water transport. This is a schedule that you see in some other form already by Professor van Biesen. These are endothelial cells. This is the capillary lumen. This is the interstitial fluid. In the case of peritoneal dialysis, it's dialysis, of course. Peritoneal cavity filled with dialysis solution. And the most abundant pores are these small pores over here that are involved in transport of water and of solutes. And the amount of water that is transported through it is dependent mainly on the hydrostatic pressure and a bit on the crystalloid osmotic pressure. But in addition, we have these ultra small transcellular pores that allow the transport of water only. And this happens by a crystalloid osmotic pressure gradient exerted by glucose, of course. Well, so what do we know about it? Well, that transport through these transcellular pores is by a protein, aquaporin 1, a transcellular membrane protein that allows water transport without the transport of solutes like glucose and sodium. So glucose and sodium cannot pass through aquaporin 1. So what you have then is free water transport driven by the glucose-induced crystalloid osmotic pressure gradient. And this phenomenon explains the sieving of sodium that occurs during very high hypertonic solutions because they induce free water transport. And you see an example over here. These are mean values of 10 patients. This is a 4 hours dialysis. Well, this is dialysis over plasma of sodium. in the beginning, it is less than 1 because the dialysate sodium is a bit lower than the sodium in most plasma sodium in most patients. So with a 1.36% glucose solution, you see a gradual rise due to diffusion. But for the 3.86% solution, it is quite different, especially here in the beginning. You see this steep decrease over here in the first part of the dwell. Plasma sodium remains stable, so it's a decrease of the dialysate sodium concentration. In this situation where you have high ultrafiltration rates, the beginning of the dwell, so this decrease is due to dilution of the dialysis with pure water. It's also called, this phenomenon is also called sieving of sodium. So this is a kind, so this can be used as a kind of semi-quantitative measurement of free water transport. So when you want to assess free water transport in your PD patients, there are a number of things you can do. First, you can look at the difference in net ultrafiltration between a 3.86% and a 1.36% glucose solution, because both solutions are subject to the same hydrostatic pressure gradient, but 3.86% is much more dependent on the crystalloid osmotic gradient. I've shown you in the previous slide that you can also use the sieving of sodium after 60 minutes as a kind of semi-quantitative measurement. And the third method is that you look at the difference between total net ultrafiltration during the first hour of a 3.86% glucose dwell, and also look at the part that is associated with sodium transport. And when you subtract these two, you have the difference, and the difference is free water transport. Well, first of all, the difference between a 3.86% and a 1.36% solution. This is a slide I personally like very much. It's a very old slide, already 30 years. But what you see here is ultrafiltration in 4 patients who all 4 developed EPS. These are time scales. These symbols are ultrafiltration obtained with 3.86% glucose, and these ones, these closed circles, are the values obtained with a 1.36% glucose solution. And you see that here in the beginning of PD, this difference is much larger than at the time of EPS. And that's not only the case in patient 1, but also over here. It's less than there. You see it over here as well, and you see it over there as well. So indeed, already indicating a decrease of free water transport. When you look at it in all patients, so not so in EPS patients in time, you see that free water transport indeed decreases, but not only free water transport, but also small pore fluid transport decreases in long-term PD. So what do we have in studies about free water transport preceding EPS? There are 2 studies. This first one is by Dr. Sampimon from my group. It was done in 12 EPS patients, and they were compared to results in 21 time-matched controls with ultrafiltration failure and 26 with normal ultrafiltration. The weak point here is that we had no histology. 4 years later, 2015, a study from Brussels was published by Johan Morel, about 7 patients with EPS. and data on sodium sieving. And he compared those with 28-time matched controls, but that was irrespective of the fluid kinetics. But the strong thing here was that they had histology on peritoneal collagen and on aquaporin-1 expression. So I'll just show you some of the results of the two studies. To start with the first study by Dr. Sampimon, here you see the time course of free water transport. So this is a time scale. 0 is the time of the diagnosis of EPS, 1 year before, 2 years, etc. This upper green line is what happened in the patients with normal ultrafiltration, controls of normal ultrafiltration. The blue line, the controls with ultrafiltration failure, and the red lines, the EPS patients. And you see that there's a very nice distinction between these three lines. You can also calculate the predictive value by doing a receiver operating curve for EPS prediction here within 1 year. Here are a number of fluid transport parameters. So when a parameter doesn't matter very much, the value you get is 0.5. So net ultrafiltration 0.54 has no discriminative capacity between EPS and non-EPS. Osmotic conductance is a bit better. Ultrafiltration coefficient also a bit better. The glucose reflection coefficient is of no value at all here in this analysis, but free water transport had a very good predictive value of 0.82. And when you calculate then sensitivity and specificity of free water transport, I'll show it here for 75 ml. So free water transport 75 less than 75 ml after the first 60 minutes of a dwell, you have the value has a sensitivity of 100% and a specificity of 80%. When you express free water transport not in absolute values but as percentage of total ultrafiltration, you see that the values are really worse. So express it as an absolute value, and we found that less than 75% has a specificity of about 100%. This is from the study from Dr. Morel from Belgium. This are his data on sodium sieving in the EPS patients, so also indicating very much reduced free water transport. And these are the control patients. What he also found was that the EPS patients had of course a very marked collagen volume fraction in the submesothelial area of the parietal peritoneum. Of course, this is what you would have expected. But importantly, expression of aquaporin-1 was normal in these patients. So that's a bit strange. On one hand, you have reduced free water transport. On the other hand, you have a normal aquaporin-1 expression. So what is the explanation for this? Again, a scheme. This is the vessel, vascular lumen. These are endothelial cells. These are the pores, so these are the small pores, and this is aquaporin-1. Under normal function, aquaporin-1, about 40% of the water transport is through aquaporin-1, and about 60% through the small pores. Here we have the interstitial tissue. Here we have the mesothelial layer. This is the peritoneal cavity. And of course, you do your measurements on free water transport and sodium sieving over here in the dialysis. So when this would be normal and this would be very much reduced, the question is, of course, what happens over here in the interstitium? Well, these are some possibilities. I think when you would have injury of interstitium of tissue, so for instance in the interstitium, then in that situation, hypoxia is an important factor, and I'll come back to that at the moment. The hypoxia leads to secretion of heat-inducible factor, and that stimulates a number of, or induces a number of other factors like PI1, so that is plasminogen activator inhibitor 1, VEGF, the glucose transporter GLUT1, and of course TGF-beta. To start with, TGF-beta, that is rather difficult in clinical medicine because measurements of TGF-beta in peritoneal effluent are not useful. TGF-beta really works at the cellular level, so I won't go into this further. But first of all, let's have a closer look at hypoxia. And the important thing is that high glucose causes pseudo-hypoxia. And this is a phenomenon that is known also in diabetic microangiopathy. Hypoxia at the cellular levels means an increase of the NADH over NAD plus ratio. So this is hypoxia, pseudo-hypoxia at the cellular level. This is what I mean with it. So when you have glucose intracellularly, it is degraded in the glycolysis to pyruvate. And during this process, you have formation of NADH from NAD+. When there's much glucose present, it's also degraded in the sorbitol pathway to fructose. And also in this process, NADH is formed from NAD+. So both these phenomena increase the NADH over NAD+ ratio, as is the case in diabetic microangiopathy. Pyruvate is normally transferred to lactate, and there you generate NAD+ from NADH. But in the presence of a very high dialysate lactate concentration, this reaction will not occur or may even go the other way around. So in that case, you would have a third reason to get an increase of the NADH over NAD+ ratio. What is important about hypoxia and pseudo-hypoxia is that it induces vascular endothelial growth factor. And we have shown in the past that effluent VEGF is related to small solute transport in peritoneal dialysis patients. But we have also shown that it is not a marker for EPS. So when we go back then, we can cross out VEGF over here and go on with PI1. PI1 is an important and interesting factor because it's a downstream regulator of TGF-beta, has anti-proteolytic activity, and is produced by fibroblasts. So also by interstitial fibroblasts, probably. And it has been shown that glucose stimulates the production of PI1. What happens in patients? You see that over here. These are again the comparison between patients who developed EPS, the upper line, and control patients. Again, 1 year before the diagnosis of EPS over here. The dialysis What is given here is the dialysis appearance rate of pi1, and you see that also 3 years before a diagnosis, it is much higher in the patients that will develop EPS than in the controls. And here you see that the decrease is really very large. So that it may be that the appearance rate of pi1 is also a predictor of EPS. When you do again, then look at the ROC curve and calculate the area under a curve, you see indeed that pi1 has a predictive value of 0.77, which is rather high when you compare it to other markers in F that you can measure in effluent, like CA125, like IL-6, and also like VEGF. So also pi1 is a predictor of EPS. And then the facility for glucose transporters, GLUT1, it is expressed on the cell membrane of fibroblasts and facilitates uptake of glucose into the cell. It's upregulated by hypoxia, and it stimulates the conversion of glucose to lactate. So this is also an interesting one. So if we then go back and ask ourselves what happens in the interstitium in EPS, I think that I've shown you that glucose-induced pseudohypoxia stimulates many growth factors, among which pi1. It also stimulates the cellular uptake of glucose from the dialysis solution, and therefore the osmotic gradient within the interstitium will decrease, which means that free water transport will decrease despite the normal aquaporin 1 expression. And you see that in the following schemes. When a patient starts from PD and has 3.86% glucose solution over here, this is the mesothelium. This is the interstitium, which is rather empty in the beginning of PD. This is the vascular lumen with an osmolality of something like a bit more than 300 milliosmol. Then as this is rather empty, the osmotic gradient that will be seen by aquaporin 1 is over here and has about the same value as in the peritoneal cavity. In long-term PD, when you have an enormous expansion of interstitium full of fibers and collagen, it's likely that you will have a gradual decrease of the osmolality because these fibroblasts take up glucose, which of course lowers the gradient. So the gradient that is seen by aquaporin 1 at this stage is much lower than in the beginning. Well, if we then try to summarize some of these results from prediction of EPS, you see here that free water transport only, and I've shown you that another way already, sensitivity 100% and a specificity of something like 80%. When you combine that free water transport with pi1, the specificity goes up to a bit more than 90%. When you combine free water transport with other biomarkers, that is really not very helpful. So the take-home message is that glucose-induced cryohypoxia stimulates the expression of GLUT1 and pi1 in peritoneal tissue. The GLUT1 decreases the osmotic pressure gradient and stimulates the collagen formation. It all results in impaired free water transport despite normal expression of aquaporin 1, and this impaired free water transport is the best predictor of EPS. And these data, in my opinion, underline the importance of longitudinal follow-up of free water transport in your patients, which can be done very easily with the techniques I just described for you. I thank you for your attention.
Thank you, Professor Raymond, for the nice, thorough lecture about the prediction of encapsulating peritonitis sclerosis. So we can take some questions, and there's one question of the audience sharing: is thickening of peritoneal membrane by CT scan, if it's complicated after infection, is a sign of ABS?
Sorry?
Is thickening of the peritoneal membrane by CT scan after peritonitis, is it a sign of EBS?
No, not necessarily, but it's more extensive in EPS, I think. And I've shown you that also in non-EPS patients, free water transport goes down, although not that much as in patients with EPS. So I think free water transport is a kind of functional representation of the amount of interstitial fibrosis.
Yeah, the second question is asking about, is there any indicator for ABS when we translated this information into clinical practice?
Yes, I think that is very simple. When you do a PET, you should do the PET test with a 3.86%, 4.25% glucose solution, and then look at sodium sieving after 1 hour. I think sodium sieving, looking at so you take after 1 hour, you take a dialysis sample and you measure dialysis sodium, and you measure plasma sodium. So that gives you the sodium sieving, which is a kind of semi-quantitative measurement of free water transport. Then you also measure volume. At 1 hour, you can calculate the total amount of free water transport by the principles of Schmidt and Lamiglia that I have shown you, and that have both been published in Kidney International. So then you have free water transport in milliliters, and that's what we do routinely, yearly in our patients. We do a PET kind of PET testing with this technique, and therefore know the amount of free water transport, and we can see that it goes down. At the moment, we don't measure PI1 routinely, but we probably should start doing that.
Thank you, Professor Raymond. Here we conclude because of time, so we'll go to the next speaker, Dr. Khalid. The mic's for you.
Okay. Thanks you, Ahmed. Thanks you, Ahmed, and thanks you, Raymond. We'll move on to the last session now. Dr. Isaac, he will have 2 consecutive talks today, and his talk will be moderated by 2 different colleagues. The first talk will be moderated by Sultan Al-Dalbahi, then Dr. Talal Al-Fadil. So kindly, Isaac, share your screen, and the mic is your Sultan.
Okay, thank you, Dr. Khalid, and thank you for the excellent organization for this event. I'm very excited to introduce to you Prof. Isaac Teitelbaum. Dr. Teitelbaum is a professor of internal medicine and nephrology and hypertension, and a director of home dialysis program at University of Colorado Health Science in Denver in United States. Dr. Teitelbaum has been an active clinical nephrologist for more than almost like 30 years. Dr. Teitelbaum serves as a consultant to industry, and he has actively participated in very numerous clinical trial and educational workshop. In addition to maintaining his busy clinical and consultative practice, he's publishing as author and co-author more than 100 articles and book chapters in very high impact and prestigious journal, and he served as a reviewer in some of those journals. Prof. Teitelbaum has served the International Society of PD, Peritoneal Dialysis, in the past as a chairperson of Educational Committee from January 2007 through December 2014. And he was president-elect from September 2014 till March 2016 for the ISPD. Prof. Teitelbaum will present an interesting talk about the delivering a high-quality peritoneal dialysis, what is matter. So before we start, I encourage everyone having any interested question to put it in question and answer in the bottom of the screen. So without any delay, Prof. Teitelbaum, the floor is yours.
Thank you, but all I see, thank you very much for that kind introduction. And I thank you all for inviting me. I only wish that I could be with you in person. I would have loved to come visit Saudi Arabia. I do not have the ability to share my screen right now. It has been taken from me somehow. I see only your...
Can you try again now?
The button is not there down at the bottom of my screen. It has disappeared. It was, I see
so the green button.
No, I know it has been there up until now, and it is gone when you went to the your home screen. Best of ASCO and Best of Astro is what I'm seeing.
The green button.
Ahmed Alewa, any advice, or will ask Isaac to re-enter again?
Yes, it's you cannot see the icon, Dr. Isaac.
Nope.
It is the bottom and the under.
I have seen it for the last 45 minutes. It's not there now.
So maybe the best way is re-entering again. Is that right, Ahmed?
It is possible, yes.
Can you re-enter again, Isaac?
Okay, give me 2 minutes.
Yes, please.
All right.
Okay, no problem. So until Isaac will be back, so just a few words maybe I'll say it in Arabic. زملاء الكرام جاني رسائل كثيرة بحكاية وقت الصلاة، فإحنا في الجمعية ناقشنا الموضوع نقاش كبير بحكم التفاوت الكبير ما شاء الله على قوة الله في مملكتنا الحبيبة بين وقت الصلاة المغرب، فما بين شمال غرب المملكة وشرقها يقرب إلى حوالي ساعة، فلذا وقت صلاة المغرب قصير جدا، فخوفا من تداخل وقت المغرب مع صلاة العشاء يعني اقترحنا أنه تستمر المحاضرات وراء بعض، وكل منطقة في وقتها يعني يستغلها الواحد خلال 4-5 دقائق ويصلي وقت المغرب ولا أن تفوته الصلاة. يعطيكم العافية جميعا، في انتظار Professor Isaac to rejoin again.
Okay, now we are in business. Share screen.
Excellent.
Yes.
Okay, we must get to the beginning.
Okay, the floor is yours. Yeah.
So only maximize the screen.
Perfect, thank you. So once again, thank you very much for inviting me. We'll switch from more basic science to a more clinical aspect, and we'll talk about delivering high-quality peritoneal dialysis, what really matters. My disclosures, I do serve on the scientific advisory boards for Liberty, which is unrelated to this talk, for Protect, which will be related to my second talk. So let us begin. Obviously, everyone, I suspect many of you are aware that the International Society for Peritoneal Dialysis has just earlier this year put out a new set of guidelines. You'll hear more about that from Professor Edwina Brown tomorrow. And in this new guideline, we are de-emphasizing the role of KT over V urea. And I'd like to explain to you a little bit about why that has taken place. There are, I'll show you two patients of my own that will explain why or illustrate why I think KT/V urea is not such a wonderful thing. And then we'll discuss what really matters. So let me tell you about two patients of mine. These are both gentlemen in their early 70s. Both have been on peritoneal dialysis for approximately 3 years at the time of their, at the time that I'm describing to you. Both of them have cardiac disease and other comorbidities. But one of them golfs several times a week, tells me that he feels great, the best he has in several years. He looks great. He has a good blood pressure. He has an albumin of 3.9. The other one complains of being lethargic. He can't walk more than 15 minutes. He tells me, I'm frustrated. I can't do anything. He doesn't look healthy. His blood pressure is marginal. His albumin is poor. So which of these patients is receiving better renal replacement therapy? Well, if you looked at the KT/Vs, you would think that this gentleman with the KT/V of 2.02 is doing well, and that this gentleman with the KT/V of 1.54 is doing poorly. I think the relationship between KT/V and a patient's clinical status is simply not there. And in terms of the measurement itself, there are inaccuracies in the determination of V. Remember, the V in KT/V is the volume of distribution of urea, which is total body water. Alterations in body composition result in erroneous estimations of the degree of dialysis provided. And this has been analyzed very, very nicely recently by Simon Davies and Fred Finkelstein in the same issue of Peritoneal Dialysis International that contains the new guidelines. They looked at the discordance in determination of total body water between bioimpedance analysis versus isotope dilution. Isotope dilution is the gold standard and gives you what total body water actually is. We can't do that on a routine basis, so we look for alternatives. So we use bioimpedance analysis in some instances. They looked at 11 studies, approximately 400 patients, roughly distributed evenly hemo and PD patients. The mean difference between the bioimpedance analysis and the isotope dilution was only 1.2 liters. That doesn't sound like it's so bad, but that's for a population of 500 patients. If you look at the level of agreement in an individual patient, not so good. Negative 13% to positive 18%. So if you take a person with a true total body water of 35 liters and the calculated KT/V of 1.7, the 95% confidence interval for what the KT/V actually is, well, it's anywhere between 1.44 and 1.94. That's a huge range. And it gets even worse when you look at the anthropometric equations, the standard Watson formula that we use in adults, or the Melitz and Cheek formula that is used in pediatric patients. And here we have some 500 patients, mostly PD because we have children who are more likely to be doing PD. The mean difference, 0.01, that's 10 ml. That's fantastic on the average, but for the individual, it's plus or minus 18%. Which means that for a person with total body water of 35 liters and the calculated KT/V of 1.7, again, the 95% confidence interval, the KT/V is anywhere between 1.44 and 2.06. It simply does not correlate. Why is this? Well, alterations in body composition result in erroneous estimations of the degree of dialysis provided. Remember, muscle has a large water content. Fat has a very small water content, maybe 7%. Patients with muscle wasting will have a spuriously small V, resulting in overestimation of the degree of dialysis provided. Conversely, patients who are obese will have a spuriously large V, resulting in underestimation of the degree of dialysis. So if we can't use V, should we normalize KT? Remember, KT is simple, the total clearance in the period of time that you're discussing. Should we use ideal body weight, adjusted ideal body weight, body surface area, metabolic activity? We simply don't know. So the summary statements from the paper by Davies and Finkelstein, and subsequently by the overarching paper, and I'm proud and pleased that I was able to be a part of that overarching paper. Given the uncertainty of the estimation of V, clinicians should be encouraged to alter the prescribed dialysis dose in response to symptoms and treatment goals, rather than simply equating a single value cutoff with adequate treatment. In other words, we can't simply say KT over V 1.7 or higher is good, 1.7, 1.69 or below is bad. And conversely, and this is where we're de-emphasizing the KT over V, if symptoms, nutrition, and volume are all controlled, no PD prescription change is needed for the sole purpose of reaching an arbitrary clearance target. So if we don't use KT over V to assess the quality of our patient's dialysis care, what do we look at? So again, I'll set the stage for Edwina's talk tomorrow and give you this statement from the guidelines talking about the importance of person-centered care. PD should be prescribed using shared decision-making between the person doing PD, their caregiver, and the care team. The aim is to achieve realistic care goals to maximize the quality of life and satisfaction for the individual, to minimize their symptoms, to provide high quality care. Okay, so let's now assume that we have a patient who is looking forward to eventually being transplanted. It doesn't have a donor, so the transplant isn't going to happen anytime soon. It's going to take perhaps 3, 4, 5 years. And this individual says, I want to maximize my quality of life. I want to maximize the longevity. I want to be in the best possible shape I can be before I undertake this transplant. What are the things we should be paying attention to? So this is a table of my opinion. This comes from a paper that appears in this month's CJSON. You can see that I have listed 10 parameters in 7 different categories. And what I'd like to do is quickly run through these with you, show you a little bit of the data and what I think is the appropriate target or the appropriate range for these various parameters. So let's begin with acid-base status. This is a study out of China where they looked at the serum bicarbonate and stratified it, looking at both all-cause and cardiovascular mortality. And they looked at patients who had a normal bicarb 24 or better, a slightly low bicarb 22 to 24, or an overtly low bicarb less than 22. And you can see that the patients with the highest bicarbs had the best survival, and as the bicarb lowered, survival deteriorated. Cardiovascular survival in particular over 4 years was quite terrible in the patients who had the lowest serum bicarb. If you stratify this another way, you look at normal bicarb 24 to 26, you'll notice that a higher bicarb, 28, 30 even, is not deleterious, but as the bicarb falls, 22 to 24 and below 22, there's a marked increase in the hazard risk for mortality. Again, whether we're looking at all-cause or cardiovascular mortality. Now, an interesting question. You practice at essentially sea level. My practice is in Denver, and people from the surrounding areas who live at an elevation of 1,700, 1,800 meters. We are walking around chronically relatively hypoxemic with a respiratory alkalosis for which we compensate by dumping bicarb. The kidney compensates by dumping bicarb. A normal bicarb here in Denver is 22. So would the 22 be deleterious here in Colorado? I don't know. So again, my recommendation is we should keep the albumin 24, keep the bicarb 24 or higher. Albumin. If we look at serum albumin and look at the normal being 4.0 or better, you can see that as the serum albumin increases, there is a tendency toward decreased mortality. We're looking again at all-cause cardiovascular or infection-related mortality. Large study out of the United States, 12,000 patients. And you can see, however, that as the albumin decreases, you get a tendency towards lower survival, increased mortality, and this begins to become statistically significant in all instances if the albumin is below 3.8. Even more important to remember that albumin is not a static value, it's dynamic. Albumin can change in people over time. It improves, it deteriorates. And here you can see that improvement in the serum albumin results in a decrease in mortality. So if the serum albumin goes up by 0.3 or more, the hazard ratio for mortality goes down. In contrast, or conversely, if the serum albumin falls by 0.3 or more, the hazard ratio for mortality goes up. And this is change over a period of 6 months. So we want to have a serum albumin of at least 3.8, and ideally we'd like to see it, if it is changing at all, we'd like to see it increasing rather than decreasing. Again, a question. Albumin is measured commonly by one of two colorimetric assays, what's called BCG, bromocresol green, or BCP, bromocresol purple. The BCG is more commonly used, and the BCG results in a higher value than does the BCP. This study was done with BCG. How does it apply to BCP? Not clear, but again, you clearly want a higher albumin with less change. Blood pressure. This is a study from the United States, from what's called the USRDS. Interesting findings. We always think of hypertension as being problematic. Now, this was a short-term study, only 2 years of follow-up. And you can see that at least over 2 years, even having a systolic blood pressure of 180 or above was not associated with an increase in mortality, but low blood pressure, less than 111, so 110 or below, is associated with an increase in mortality. This is a study slightly larger, 2,700 instead of 1,100, and it's a 6-year study rather than, or 6+ rather than just 2 years. It corroborates the early finding that low blood pressure is deleterious, high blood pressure is better. But by the time you get to year 6 or later, we do need to pay attention to blood pressure. But at least early on, it seems that we could safely tolerate a blood pressure clearly to 160. And I think if someone is walking around in year 1, 2, 3 of peritoneal dialysis with a blood pressure of systolic blood pressure of 160, and they're already on multiple medications, and we would need to torture them with more and more pills to get their blood pressure down further, the evidence does not support the need to do so. Electrolytes. Let's start by talking about potassium. As you all know, in peritoneal dialysis patients, hypokalemia is far more common than is hyperkalemia. And how low is too low? Well, in normal people, we tolerate potassiums generally as low as 3.5 is the lower limit of normal. But as I'll show you in several studies, the evidence is that for peritoneal dialysis patients, 3.5 is too low. This is a study, a large study, 10,000 plus patients with potassium of 4 to 4.5 milliequivalents per liter used as the reference point. As the potassium falls, even if it's 3.6, 3.7, there is an increase in all-cause mortality, and there is an increase or tendency towards an increase in infection-related mortality. This is data from the US. Here's data from China. Again, increase in mortality, all-cause or cardiovascular, as potassium falls below 4. Here's data from Brazil. So very, very concomitant or concordant data from around the world. You want to have the serum potassium at least 4, and in many of these studies, you could go safely as high as 5.5. Serum sodium is very interesting. We commonly think a sodium of 136, 137 is fine, and obviously we have many of our PD patients walking around with sodiums 132, 133. And I'll show you that that may not be a very good idea. Here's the time-dependent serum sodium. This is a study, this is US data. Here we have 140 to 142. And you can see that as the serum sodium falls, even if it's still 134, 135, 136, there is a 50% increase in the ratio, in the likelihood of mortality. And here's a study, a larger study out of the United Kingdom, where they found that even here, this bottom line, these are people with a sodium below 138. 138. So if you're at 136, 137, you have an increased risk of mortality. The Kaplan-Meier survival curve is worse. When we treat patients with icodextrin, there's a small number of patients who will have a decrease. There is a number of patients, I should say, who will have a small decrease in the serum sodium by 2 to 3 milliequivalents per liter. And the sodium may fall from 136 to 133. Is that decrease important? Don't know. What about hemoglobin? Here's data. I'll show you 2 studies from the United States. And understand these are all patients treated with an ESA. You know, in the hemodialysis patients, there's data that the higher the ESA dose, the worse the patients do. And I'll show you that this data does not seem to pertain in peritoneal dialysis. To the contrary, with a hemoglobin below 11, patients do worse. Here you can see, again, whether we look at first hospitalization or mortality. Let's focus on the mortality, whether we look at non-diabetics or diabetics. The darkest bar, the second one from the right, is patients with a hemoglobin 11 to 11.9. You can see that the patients with the higher hemoglobins do no worse. They may or may not do better, but they do no worse. In contrast, statistically significant increases in mortality, even with a hemoglobin between 10 and 10.9, and certainly below 10. So it looks like the best hemoglobin is 11 or above. And similar data from this study, where you can see 11 to 12 as the reference point. This is a large DaVita database, 9,000 patients, again, all treated with an ESA. And you can see that compared to 11, as the hemoglobin falls below 11, there is an increase in all-cause mortality. There is an increase in cardiovascular mortality. So you want to keep a hemoglobin of at least 11. Moving on to mineral metabolism, calcium, magnesium, phosphate. Here's calcium data, and this becomes, in a sense, a little repetitious, all these U-shaped curves, but you can see that if you correct for albumin, you want to keep your calcium roughly 8.5, 9 on the low side to as high as 10.3 to 10.5 on the higher side. And out of that range, the patients do less well. Okay. Magnesium was very interesting to me when I looked at this, because I, for one, do not routinely monitor magnesium in my patients, and yet the effect seems to be a pretty significant one. If you look at a normal magnesium, 0.7 millimolar, which translates for us here in the States to 1.68, let's call it 1.7 milligrams per deciliter, we have plenty of patients with magnesiums of 1.5, 1.6, and both their all-cause mortality and their cardiovascular mortality would appear to suffer. And finally, in the mineral category, phosphorus, you can see that we have patients with a phosphorus up to 6.3. There is no deleterious effect. So we spend a lot of time and effort to try, and that 6.3 translates to about 2 to 2.1 millimolar. So 6.3 or under seems to be fine. We have a lot of patients with phosphoruses of 5.9, 6.2. We expend a lot of time and effort and have them expend a lot of money to buy the medications, and they have the burden of taking the medications, and you can't demonstrate the benefit. So I think we can afford to perhaps relax a little bit on the criteria for phosphorus and not get excited until they hit this level of 6.4 or higher. And finally, I'll say a few words about volume status. This is old data out of Turkey, where you can see if we look at total fluid removal. So this is the combination of urine output plus ultrafiltration. And you can see that more is better. If they get out 2 liters a day total, they do much better. Now, obviously, this may relate to the persistence of some residual kidney function. There are potential confounders. But the more fluid you get off, the better you do. The less fluid removed, the worse the patients do. This is data looking at the N-terminal pro-BNP, the precursor molecule for BNP that we use in routine practice. This is elaborated by the stretched myocardium, and the N-terminal pro-BNP has a longer half-life, and therefore its level is probably a better marker of average volume status. And you can see that the patients with the highest N-terminal pro-BNP have the worst survival. And very recent data from just last year from Wim van Biesen and colleagues, where they looked at volume overload. I don't remember exactly how they got to this number of 17.3%, but this volume overload gave you a 60% increase in the likelihood of mortality. So again, it's difficult, as I mentioned earlier in the talk, it's difficult to know exactly what total body water is. They used bioimpedance analysis, but at a bare minimum, when we use our clinical exam, we should be able to state that our patients have no overt evidence of volume overload. We want them to be free of edema. You want them to be free of RALs. So in conclusion, I think focusing on KT over V urea as an indicator of peritoneal dialysis adequacy or quality is simply not justified. In contrast, there are a number of other parameters for which, if we achieve a desired level or range, it does look like that it's associated with clinical benefits. Now, I have to stress, all the data I showed you is retrospective observational data. It's not prospective randomized controlled clinical trials. And in an ideal world, we'd like to have those randomized controlled interventional trials to assess the validity of these observations. I'm not convinced those trials will ever be done, but that's ideally what we'd like to have. And again, setting the stage for Edwina tomorrow, clinicians should take a holistic and goal-directed view of the person performing PD to assist him or her in achieving their own life goals. Thank you very much for your attention.
Thank you, Prof. Tsolban, for this very excellent and exciting, interesting talk regarding the quality of PD and how we optimize that and the parameters of that. Really, we enjoyed the talk. And now we will have some questions from the audience related to the presentation. So here's the questions from one of the audience about how to maintain the albumin between 4 to 4.20 in a patient in a cheap way he just took from the economic perspective?
That is a great question. It is very difficult to maintain the serum albumin. I am confident that albumin is not just about nutritional status. We have patients who eat poorly and have good albumins, and we have patients who eat well and we stuff them full of protein shakes and supplements, and they still have a low albumin. I think the albumin is about inflammatory status. There is a study that came out, I think a year or so ago, in hemodialysis patients looking at a IL-1 receptor antagonist, so to decrease inflammation and looking at the effect on albumin. And there was some preliminary data that was very, very favorable. And hopefully we'll be able to apply that data to the peritoneal dialysis population as well. But I agree with the questioner that it's easy for me to say keep the albumin higher. It's a lot more difficult for us to accomplish it.
Yes, thank you for your answer. There's another question about how we could explain that the higher hemoglobin may be better in BD and compared to the hemodialysis population.
So one of the observations is that the doses of ESA needed to maintain a good hemoglobin in patients on peritoneal dialysis are much lower than the doses used in hemodialysis, probably because of ongoing blood loss through the dialyzer with every dialysis. Whatever it may be, the doses in PD are much lower. So to the extent that let's keep in mind, we're all walking around with hemoglobins of 13, 15, 16, and we're doing fine. So it's not that a hemoglobin of 13 is intrinsically deleterious. It's probably that the dose of ESA necessary to achieve that higher hemoglobin is what's deleterious. Well, if you look at 1,000 PD patients compared to 1,000 hemo patients who have a hemoglobin of 12, the average ESA dose in the PD patients with the hemoglobin of 12 is much lower. So if we're looking at adverse effects of the ESA, well, we're dealing with much lower doses.
Excellent. There is a question about the magnesium level. Do you actually do anything about it in a clinical practice in a BD? Or just
if my patients are hypomagnesemic, I will supplement them, yes.
Yes.
And remember, they're prone to it because the magnesium content of the peritoneal fluid is quite low. It's about 0.75, if I'm not mistaken.
Yeah. There is another interesting question regarding, does hemoglobin A1C do anything about the quality? Like, is there any similar observation regarding the hemoglobin A1C, the glycemic control, and diabetic patient on BD?
I do not remember seeing that data.
Okay, so it might be a very great area of research.
Could be, yeah, for the diabetic patients, it would be an interesting area. I don't remember. I'd have to search and see if it's been done, but I don't recall seeing it.
Okay, there is another question regarding how can we explain the mild minimal hyponatremia and increased mortality? Is it related to the patient background, cardiac status, volume overload?
So it hasn't been carefully studied in peritoneal dialysis. In hemodialysis, there is some data that even mild hyponatremia can be associated with some cognitive impairment. You can get some cerebral edema, and it is speculated that you might get tissue edema. There's also data, again, in the hemo population, that there is an increase in infection in patients who are hyponatremic, pulmonary infections and gastrointestinal infections. Now, might there be an increase in peritonitis in patients who are hyponatremic? Could that translate into an increase in mortality? PDOPS is actually looking at that question, but we don't have an answer just yet.
Yeah, there is a question about regarding the KT over V. Is the message that to decrease the frequency or even to stop assessing that one and for assessing the PD adequacy?
So here in the United States, we are still mandated by our government to measure KT over V. So I have to tell you that I have no choice but to keep measuring it. At the same time, I can tell you in Canada, I have colleagues who just don't bother measuring it at all. And they look at how their patient is doing clinically. They look at these other parameters that we've discussed. And if the patient feels good, looks good, functions well, and is doing well in terms of these other parameters, they don't check. And their patients aren't doing any worse than anybody else's.
Clear. Okay, finally, there is one question. Actually, two questions. I'll try to modify the question toward the session scope. Asking about the COVID-19 patient. Is there any recommendation to maintain the high quality PD and patient with COVID?
So we have had a number of patients on PD with COVID. It is so difficult. I think it's very difficult to clinically dissect what effects of those patients or what findings in those patients would be due to COVID and what would be due to inadequate or insufficient peritoneal dialysis. As you know, they get terribly inflamed and they could become profoundly anemic, hypoalbuminemic. I don't see how I would be able to sort out what is dialysis related and what is COVID related.
Okay, I think we will close in this stage. I really, get very interested and enjoy the talk, and as expected and as usual. Thank you so much for this very comprehensive, very excellent presentation. And I will leave the mic to the next moderator to present the next sessions. Thank you, Prof. Titelbaum.
Thank you.
So the speaker is the same, still Professor Isaac, and the moderator is Talal Fadel. The mic is yours, Talal.
Yes, thank you, Professor Titelbaum, and thank you, Sultan, for moderating the previous session. I'm really excited about this next lecture, which is the future of PD in the world. I'm excited to present Dr. Isaac Titelbaum. For those who are just joining, he's a professor of medicine and nephrology from the University of Colorado, with significant contribution to the ISPD. With that, we'll go ahead and start, inshallah.
Perfect. Thank you so much. And once again, thank you all for inviting me. And again, I just wish I could be there in person. So the future of peritoneal dialysis in the world, I took out those three words deliberately because rather than discussing the prevalence of peritoneal dialysis and the political factors that might go into the spread of peritoneal dialysis, whether there will be PD first and so on, I wanted to talk about the delivery of the care of peritoneal dialysis. Now, the future. Some of you may be familiar. Yogi Berra was a very famous baseball player here in the United States, and he used to say some very interesting things. And one of his famous quotations was, "It's tough to make predictions, especially about the future." So obviously I'm walking out on what we call thin ice. But what I'd like to discuss with you are what's upcoming in technical aspects of therapy delivery. How might we improve our early diagnosis of peritonitis? And what might we do to protect the peritoneal membrane? You heard from Franz Schaeffer about effects on the membrane. You heard from Dr. Kredit about effects on the membrane. What might we do to protect the peritoneal membrane? So again, let's begin with technical aspects of therapy delivery. And I'll start by discussing the wearable artificial kidney. There are a number of places looking at this potential for a wearable artificial kidney. You can see that some are using the hemodialysis system, some are using a PD system. We're talking about peritoneal dialysis, and I'm going to focus on this one automated wearable artificial kidney PD system coming out of Singapore. And the reason I'm going to focus on this one is it seems to be the farthest along, and it's the one that has been granted, designated as a breakthrough device here in the United States by the FDA. The data is rather preliminary, rather limited, but this is what there is that's been published so far in preliminary form. You have 15 patients who were treated thrice daily, 3 times a day, for 3 days. These are patients who were already on peritoneal dialysis, and the pre-AWAC values show you where they were in their standard of treatment. And then they use the AWAC for 3 days, and you can see that their urea fell, their creatinine fell, their phosphate fell. And then a month later, back up to the pre-treatment levels, and these were all significant. While I've just spent some time telling you that I don't think KT over V is all that important, they measured the KT over Vs, and you can see that they uniformly got good KT over Vs. Obviously, some of these very, very high levels include patients who still have good residual kidney function. In some instances, it must have been so good that I question why they were on dialysis, but that's another issue. And this is a picture of the device. It's a small device. It's portable. You can wear it slung over your shoulder with a shoulder strap, and it connects, of course, to a peritoneal dialysis catheter. Well, I'm a little skeptical. I think it remains to be seen whether this technology will be widely embraced. I question whether people will want to wear a device during the day, carry it around, in a sense, making an announcement, hi, I'm a PD patient, and having to deal with the nuisance of wearing or carrying this. I understand that they're working on putting it all into a vest that the patient will be able to wear. But is that really better than just hooking up for 7-8 hours overnight and doing nocturnal PD? So I'm a little skeptical. On the other hand, I'm far more enthusiastic about the concept of online generation of peritoneal dialysis fluid. This is a picture of a patient's supplies for peritoneal dialysis. This is 1 month's worth of supplies. As you can see, it's rather bulky. This is approximately 30 cubic feet, which by a quick calculation, it's around a cubic meter, if I'm not mistaken. So it occupies a fair bit of space. It's heavy, and for a patient to hook up, if they're using a 6-liter bag, well, remember 6 liters is 6 kilos that they have to be able to lift. And it's inconvenient. Every month you've got to be home to get your delivery, and it takes up a lot of space. So if we could generate fluid online, point of care, sitting in your home, can you generate the fluid you need to use for your dialysis real time? Well, both Baxter and Fresenius, through its next stage arm, are looking into this possibility. Baxter has completed a small clinical trial of 14 patients. I just spoke to representatives of these 2 companies within the last 2 to 3 weeks to get their most current information. Baxter has completed a small clinical trial. They hope to publish their results next year. What they would share with me is that, yes, it is technically feasible to do this, but they're unclear if it's how practical it is, either for the patients and, quite frankly, from a business standpoint. So these are things that they're going to need to sort out. FMC, through its next stage arm, is working through 2 different approaches for the point of care or on-site generation of PD fluids. They have not done a clinical trial. They do not have a timeline. And as I said, I think it remains to be determined how practical these will be. I would be interested in seeing whether one can alter the glucose. Are we fixed to 1.5, 2.0, the dextrose, 1.5, 2.5, 4.25%? Or can we lower it maybe to 0.5%? I know in Singapore, for example, there is commercially available a 0.5% fluid. When would you use that? Well, a patient who needs solute dialysis, but not a lot of UF. Maybe somebody still puts out 1.5 liters, 2 liters of urine a day, but needs solute clearance. So you might use that fluid. Could you use it with icodextrin to generate icodextrin? These are things that remain to be determined. But if we do succeed with online generation of PD fluid, I think it's going to be a big deal. I think it stands to revolutionize PD therapy for people already on therapy at home. I think it will attract more people to do PD if they don't have to deal with these huge supplies. It has the potential to open the use of PD therapy in remote areas. You won't have to ship as much stuff. And if you think out of the box and think beyond end-stage kidney disease to AKI, it should help make treatment for AKI accessible to many more patients around the world. But obviously, to generate fluid, you need water. What if water itself is scarce? So there are two systems. The one is rather complex, but it's the new filtration system. They take used hemodialysis filters, put them in a chain, basically, up to 500 filters in parallel and in series, and you can generate 500 liters an hour of dialysate, of water, 500 liters an hour of water, which you could then use to form the peritoneal dialysate. And it's nice, it can work with a hand crank, you don't even need electricity. What if you're in an area where there's essentially no water at all? Well, here's this contraption, a device called WaterGen, that a company called WaterGen has an instrument that condenses water vapor from the air. The units are going to come in various sizes, but the smallest one that they call Jenny, which they say will be available commercially within the next few months, first quarter of next year, it has a production capacity of 30 liters per day. So 30 liters per day means that we could get 3 to 4 adults treated with peritoneal dialysis and many, many more children, obviously, who require much less fluid. The purchase price is not bad, $2,500, and the operating cost, 3 cents per liter. So for $1 a day, you can generate 30 liters of fluid and can treat a large number of people. So I think that if we succeed with the online point of care generation of PD, that'll be a major advance and it will enhance availability of PD around the world. Introduction of advanced water purification and generation technology will allow PD to be performed even in remote areas without adequate water supplies. And again, this will save lives. I think this will be a big deal. Let's turn our attention now to the person who is on peritoneal dialysis. And obviously, the most common complication of PD is peritonitis. Right now, to diagnose peritonitis, you need a culture. That takes days, right? In up to 20% of cases, that's what the ISPD says is okay to have, and in many centers it's higher than that. You fail to identify the organism, and you have with what you think is culture negative PD. So what do we do now? We have a patient who presents with suspected peritonitis, and we start them on antibiotics. We choose antibiotics empirically, and we choose broad coverage for gram positives and gram negatives. And two things happen. Patients are sometimes delayed in getting the proper antibiotic because the antibiotic you chose Vanc and Ceftaz, and maybe the patient, the organism is not susceptible to ceftazidime. Conversely, some patients are getting broad spectrum coverage when all they needed was something very narrow focused. Can we diagnose peritonitis earlier, more quickly? So I'll show you two things. Gene sequencing. Now, let me acknowledge, I am not a microbiologist and I'm not a molecular biologist. So please don't ask me technical questions about what I'm saying here, I can't answer them. But the 16S ribosomal RNA gene is a section of prokaryotic DNA, i.e. bacteria, and it's found across the board. There are conserved regions so that they're going to be the same in every organism, but then there are these variable regions that differ between bacterial species. And you can use the ability to identify these variable regions as a technique to know what organism you're dealing with. And this is commonly done after culture to identify the organism. The question is, could it be used before culture to determine the presence or absence of bacteria in peritoneal fluid and the identity of the organism? So here's a study from Malaysia where they looked at the 16S ribosomal RNA gene sequencing. 91 patients suspected to have peritonitis, 45 of whom actually had peritonitis. Culture identified 35 bacteria and 2 fungal infections, and with the 16S RNA, they picked up all of those, as well as 1 additional bacterial infection. And you can do this in a few hours. Now, at least in the United States, it's not approved for routine use in clinical testing, and it's unclear if you could use it on dilute fluids, although it seems that you can, as evidenced by the study in Malaysia. It's not covered by insurance. That, of course, is a technical issue that can be resolved. And as I say, if you send it out, it can take days, but in your lab, if you're set up to do this, it can be done in 5 or 6 hours. Well, that's nice. 5 or 6 hours is pretty good, but let's say you have a patient who comes to your clinic with cloudy fluid and you want to know whether or not they have peritonitis. You don't want them sitting around for 5 or 6 hours before you decide whether or not to give them antibiotics. Or you have a patient who lives in a remote area and it's a nuisance to come to the clinic if they don't have peritonitis and something else is going on. Is there a way that you could do point of care testing in the patient's home, perhaps, certainly in the clinic, and find out in just a few minutes whether or not this peritonitis? Well, it turns out that such assays are existing and will become, I think, more prevalent. This is Periplex. This is a test developed in the United Kingdom by a company called Mologic. Andrew Davenport and his colleagues are the people who have developed this. This is essentially a dipstick of the peritoneal dialysis fluid. It utilizes this technology called lateral flow immunoassay, and it detects 2 inflammatory mediators: matrix metalloproteinase 8, which is produced by activated neutrophils during acute inflammation, and interleukin 6, which increases early in peritonitis. And you can get results in 5 minutes. And here's what this is predicated upon. In 107 patients, if you look at patients who are stable versus when they develop peritonitis, you can see that the interleukin 6 level increases dramatically. Similarly, matrix metalloproteinase 8, there's really nice separation between the patients in the stable condition and those who develop peritonitis. Each of these highly statistically significant. Ray Kredit was talking earlier about receiver operating curves, and when you have an AUC of 0.8, 0.82, how fantastic that is. Well, look at these AUCs, 0.96, 0.98. This is an incredible predictor for the presence of peritonitis. And it's very simple technically. It's this dipstick, and you have basically 4 possibilities. You need to have this one line show up to prove that the control has worked appropriately. Okay, so you need the control to work. You have a line that shows up if MMP8 is detected, a line that shows up if IL-6 is detected, or of course you can have both. So this is a control. It's done correctly, but it's a negative test. This is MMP8, IL-6, or both. And here's what happens when you look clinically at 107 samples. 49 were positive, 58 were negative. So how good is the test? Let's start with the negatives because it's very, very straightforward. Of the 58 negative, 57 did not have peritonitis. So your reliability to rule out peritonitis is incredibly good. There was one patient who was treated for PD peritonitis. The suspicion is that this was a previous partially treated event. What about the 49 who were positive? Well, of them, 41 had a diagnosis of PD peritonitis. 8 did not have peritonitis, but of those 8, 3 were septic systemically, 3 had other intra-abdominal infections, only 2 were not infected. So if you look at the summary, there's only, out of 107, only 1 false negative. There out of 58, 1 false negative, 8 false positives, but of those, 6 had another indication for antibiotic therapy. So you're not going to go wrong by treating those patients with antibiotics. All together then, 98% sensitivity and 88% specificity. And remember, this can be done at home. Now, all it does is tell you peritonitis, yes or no, doesn't tell you anything about the nature of the organism. Are there tests? Can this be taken a step further to distinguish between gram-positive and gram-negative so that you could further narrow your antibiotic coverage? And the answer is, it looks like we'll get there. This is a study out of India where they looked at the role of TNF-alpha and interleukin-10. And you can see that TNF-alpha goes up nicely in gram-positive peritonitis, but not in gram-negative. That's here. IL-10, the distribution or the separation was less impressive. You have it high in gram-negatives. Now, what they didn't tell me is if you have a high IL-10 and a low TNF-alpha together, how reliable that is. But I do know that the people who have developed Periplex, when I had communication with Dr. Davenport, they are working on further advancing this, such that hopefully in the future it'll be possible not only to do a dipstick and say peritonitis, yes, no, but to distinguish gram-positive from gram-negative. And lastly, let's talk for a bit about the importance of protecting the peritoneal membrane. You've heard 2 talks previously, one from Franz Schaeffer, one from Ray Kredit. And Franz actually showed one slide about the compound I'm going to discuss in a little bit greater detail. This schematic is probably familiar to you. Glucose forms GDPs and advanced glycosylation end products together with the effects of peritonitis, the uremic milieu, the acidic pH fluid. Many pro-inflammatory and pro-fibrotic mediators are generated. These result in mesothelial denudation, transdifferentiation, collagen and extracellular matrix deposition, neoangiogenesis, vasculopathy, all of which translates into ultrafiltration failure and a high transporter state. So is there anything we can do to protect the membrane from this and prevent these complications? There's a whole host of things that have been looked at. Somebody asked a question about COX-2 inhibitors. You can see here, celecoxib has been looked at. Many, many things have been looked at. This could be a 3-hour talk just to go through all of these. But I'm going to focus on this one compound, alanyl glutamine. Now, why alanyl glutamine as opposed to glutamine alone? Because this dipeptide is more stable and more water soluble, but the idea is to be able to deliver glutamine to the peritoneal space. Glutamine is what's called a conditionally essential amino acid. That means that under normal conditions, we have enough glutamine. The body manufactures enough. So it would be considered non-essential. But during periods of stress, physical trauma, when conditions associated with muscle wasting, demand exceeds supply, and then it becomes conditionally essential. And if you look at the effects of glutamine, it has many beneficial effects on the whole organism. It enhances immune function. It promotes wound healing, may increase muscle mass. We see patients in our burn unit, patients who are severely injured, who are getting large quantities of glutamine. And at the cellular level, it shows cytoprotection, and it's associated with activation of the cellular response system with increased heat shock proteins, which of course are cytoprotective. So if we look at human peritoneal mesothelial cells in culture, so this is an in vitro is where you start, and you expose them to peritoneal fluid, look what happens. We're looking at dead cells. How many cells die? So if you just grow the cells in culture, nobody dies. And if you expose them to glutamine, they live nicely. If you expose them to peritoneal dialysis fluid and wait several days, 50% of the cells die. If you expose them to PD fluid and expose them as well to a compound, this DON compound listed here, that decreases glutamine, even more cells die. If you supplement with glutamine, fewer cells die. And if you use the inhibitor of glutamine, but supplement with glutamine, compare here to this, fewer cells die. So glutamine supplementation is a good thing. What about in man? Well, this is a short-term study, 20 patients, where they did a PET test with 3.86% glucose, either alone or with the addition of this 8 millimolar alanine glutamine. They did them in random order, random sequence. They separated them by 4 weeks. And they looked at small solute transport and UF. They looked at the heat shock protein expression, metabolomics, immunocompetence assays. And here's the preliminary data. And you know, we say in Latin, they say primum non nocere, first do no harm. So we demonstrated in this preliminary study that there was no harm. And if you look at the p-values, no differences. And that's if you look at the transport characteristics or the immune markers. And here you can see, however, that if you look at the heat shock proteins, which again are cytoprotective, you can see that whether you look at the median or the mean, they both increased. A little difficult to see. The median is in the red lines, red bars, the mean is the gray lines. And finally, they did a randomized control trial, multi-center trial to assess the impact on biomarkers of peritoneal health. 8 Austrian PD centers, 8 weeks each of the standard fluid and fluid supplemented with the 8 millimolar alanine glutamine, random order, randomized the patients to which sequence they should be in. They looked at the PD effluent collected during a 3.86% PET. They looked at the appearance of CA125, which is a marker of peritoneal cell mass. They looked at the stimulated interleukin-6 release at 1 hour as a marker of peritoneal immune competence. And here's the data. Whether you look at the full analysis set or the patients treated per protocol, bottom line, with the alanine glutamine, you had an increase in the CA125. You had an increase in stimulated interleukin-6 release. So very promising, still early data, still relatively short term, only 2 months. And if you look at the peritoneal transport characteristics, you can see the important thing here is that there is a decrease in peritoneal protein loss, 2.6 to 2.1 as grams per in 4 hours. So these are very promising early results. We're going to need a larger phase 3 trial to examine this more clinically, to examine more clinically relevant endpoints. Is there a difference in peritonitis? Does it affect residual kidney function? What does the peritoneal membrane look like? We're going to need some biopsy data. And bottom line, does it result in prolonged survival? And this trial is being planned. So my predictions, using my crystal ball to predict the future. Wearable PD technology for use while engaging in usual activities will be available, but I'm questioning if it'll be widely embraced. Point of care generation of PD fluids coupled with increased availability of suitable water supplies should result in increased uptake of PD in developed nations and enhanced global availability of PD for both AKI and end-stage kidney disease. Point of care testing for peritonitis will become widely available. I'm very optimistic of that, and I'm cautiously optimistic that it will include the ability to discriminate between gram-positive and gram-negative infections. And finally, the jury is still out, but I'm optimistic, I'm hopeful that alanyl glutamine will prove to have beneficial effects. Thank you very much for your attention. And again, thank you for inviting me to join you.
Thank you so much, Professor Tittabam. We have a few questions. Some are very interesting and some are out of the scope of this lecture. So I'll go to the first question, which is, do you believe that periplex can have cross-reactivity with other causes of peritonitis, like acute abdomen or ruptured peritonitis?
Yes, I think it does. And I think their data showed you that of the 8 patients with periplex positivity who did not have peritonitis, 6 of them had other causes, 3 of them were other intra-abdominal infections. But you could argue that, okay, but these are patients who need to be treated with antibiotics, so it's not so terrible that periplex gave you a positive. But the answer is yes, it's not going to be totally specific to PD peritonitis.
Excellent. There were some comments about, do you believe that the hazard of wearable PD devices may limit its use in the future? So whether being injured in the public or while wearing the devices, what do you think the potential complications for that?
Potential complications of what? I'm sorry?
Of injury while using the wearable PD devices.
Yes, obviously the manufacturers, I assume, are cognizant of this, and they're going to do what they can to prevent or minimize the likelihood of such injury. If the whole thing is self-contained in a vest, then there shouldn't be a serious problem, but there is going to be some potential for an adverse event, more so than somebody simply lying in bed.
Okay. The other one that I had is actually a question from me. Do you think there would be a role for the 16S gene sequencing testing for people who are culture negative peritonitis?
Absolutely. Absolutely, I think there would be. And there's another study, in the interest of time, I didn't show you, but there was a study out of India where they actually applied that, and they show you a long list. It's not a very well-written study, and it's not a very well-done study, but they do demonstrate their ability to culture some unusual organisms not to culture, but to identify by PCR some unusual organisms that were not picked up on culture.
That's excellent. I think in the interest of time, we'll wrap it up here. I would like to thank you once again on behalf of the Saudi Society of Nephrology and Transplantation for these 2 excellent lectures. I'll pass it on to Dr. Khalid.
Yes, thank you very much, Professor Isaac. And I would like to thank all our valuable speakers and our panelists. Also, I will thank all our participants who attended today, which they are approaching almost 4,000 attendees. Thanks you very much. So we'll conclude today, and we'll see you tomorrow, inshallah, at 4 o'clock p.m. Riyadh time, inshallah. Thank you very much. See you again.
Thank you.